Son los que más saben de eso de Turquía. Yo soy
Ladies and gentlemen, it gives me great pleasure to welcome you in this series of webinars organized in collaboration with the World Federation of Neurosurgical Societies, the WFNS, the Mediterranean Association of Neurological Surgeons, the MANS, and the Continental Association of African Neurosurgical Societies, the CANS. We started our webinar on 29th May 2020. This is part of our 100 project webinar, which was initiated with beginning of the COVID-19 pandemic. We already organized 70 webinars. Many of them are WFNS educational symposia. Today's webinar number 71, and this organized in collaboration with the Craniovertebral Junction and Spine Society. In this occasion, I would like to thank my dear friend, Professor El-Ghandour, for the opportunity to have such wonderful collaboration. First of all, I would like to thank all our distinguished speakers. I will go by the order by which they speak. Professor Mehmet Zelili, Vadim Valstev. Professor Mehmet Zelili is well known. He is from Turkey. Vadim Velstev from Russia, Oscar Alves from Portugal, Virendra Sinha from India, of course, El-Ghandour from India, Nick Thomas from UK, and Girish Solanki from UK as well. Thank you for contributing to this neurosurgical activity, and thanks to all of you for giving us much of your time and sharing your knowledge with neurosurgeons across the globe. I'd like also to send special thanks to Professor Tito Perella. He is from Bogota, Colombia. Professor Tito Perella is well known and he doesn't need any introduction. He is going to be the moderator of this session with Professor El-Ghandour. Thank you very much. As you can see from the screen that we have an outstanding program which is divided into 3 sessions. And at each session, we have discussion. Each session will be 1 hour. This webinar will be finished 3 p.m. GMT. As you can see from this screenshot, until yesterday, we had 735 registrants over Zoom. And they are registering in the last week for this important event, 735 registrants for this activity. Thank you very much for joining us, all of you. To all attendees, we are glad to get all questions and comments, and this will be monitored by the moderators through the Q&A panel. This is the kind of certificate we are offering. This certificate will be sent to you automatically after the webinar. You don't need to ask about the certificate, but please, if you need certificate, participate for all the webinar. You have to participate at least for 3 hours in order to receive your certificate. These are the rules which are put by the organizing committee that in order to get certificate, please participate for minimum is 3 hours. Our series of webinars is organized either in collaboration with the Education and Training Committee of the WFNS, scientific committees of the WFNS, neurosurgical societies, whether national, regional, or continental, and sometimes well-known universities like University of Miami. The maximum capacity of each webinar is 500 registrants. However, in some webinars, the local organizing committee extend the capacity and open registration again for a limited time. This table shows the number of registrants and participants over the last 15 webinars. As you can notice that the maximum participation exists in the WFNS educational symposia. If we take example, our last webinar, which was webinar number 70, 657 registered for that webinar, but not all the registrants participate in the webinar. Only 338 participated, and not all of them received certificates. Certificates were sent to only 157 participants, those who participated from the beginning to the end of the webinar. Our series of webinars is also available over the YouTube channel. This is the QR code if you like to scan it. However, uploading our webinars to the YouTube channel is a decision which is sometimes taken by the local organizing committee, but not for all our webinar series. I'm also glad to announce about the Pan-Arab Journal of Neurosurgery, which was relaunched recently. I'm glad to be the editor-in-chief of this journal. This is the QR code if you like to scan it, and this is the address. Submit your article. Submission and publication, both of them are free. Important announcement about the 18th World Congress of Neurosurgery, which takes care in Cape Town, in this beautiful city in South Africa, from 4 to 8 December 2023. Our dear friend, Professor Graham Figin, is president of this Congress. He is doing much effort with all the organizing committee members to make it a great success. We need your support. Please participate in this important event and submit your abstracts. The deadline of submission is June 2023. Another important announcement about the 14th Asian Congress of Neurological Surgeons Congress, which takes care in Egypt, 28 to 30 November 2024. I'm glad to be president of this Congress, and I'm glad to work with Professor Yuko Kato, who is president of the ACNS. Of course, all of you are invited to participate in this important event, and I think it will be a good opportunity to visit together the Grand Egyptian Museum. Thank you very much. Now I give the mic to Professor Atul Goel to say his welcome note, and then Professor Tito Perella, the moderator of this session, to start the scientific sessions. Thank you very much.
Thank you, Nasser. As we heard from Nasser, and we heard his achievements and his various activities that he's doing for various societies in the world, there is no question in my mind that he's our leader and he has great potential to go very further ahead. And I can send you my best wishes, Nasser. And I look forward to your programs, to your journal, and to your achievements. My best wishes, and I'm looking forward to all of this. The other beautiful thing I can see on the screen are my friends who are sitting from all over the world. And many of you I know for a long time, many of you I have worked with and enjoyed working and participation in various activities. And needless to say that all of these people on the screen are accomplished people in the field of craniovertebral junction and in spine. They are not just accomplished, they have achieved and they have contributed a great lot to this subject. At craniovertebral junction surgery is difficult, it is complex, it is philosophical, it is technical, it is anatomical. Everything is involved in craniovertebral junction surgery. We can give new life to our patients, and we can actually, if we don't understand, we can damage the patient. So with these few words, I give it to my dear friend, Tito Perella from Colombia, Bogota, and you just see his face. He's such a kind person. He's such a good friend. And Tito, over to you. Please conduct this beautiful activity and let's enjoy this webinar. Thank you very much.
Thank you.
Thank you, Professor Nasser and Professor Atun. That you said before, this is very important review of this difficult pathology. And we have to start with the first speaker, who also is one neurosurgeon who is very well known because he was a past chairman of the committee of the spine of the WFNS. And in my opinion, and maybe many neurosurgeons all over the world share with me this concept. She did a lot of effort for trying to raise and recovery the issue of the spine have to be handled for neurosurgeons. Also, we have to combine some activity with orthopedics. But in my opinion, all his effort is to try to save this very important field in our hands. And for his conference of Dr. Cieli, he will be talking about reduction techniques for basilar invagination. Welcome, Dr. Cieli.
Thank you, Professor Tito. It is a great honor to be with you all. I thank all the participants and all the faculty members. I'm sharing my screen. What is that? Do you see my screen now?
Yes.
Okay, thank you. My topic will be the reduction techniques for basilar invagination. Actually, reducibility and reduction methods is not a new concept, and it was first described by Dr. Menezes in many years before. You can refer to his paper from 2017. One main concept is that preoperative images may not be enough for decision of reducibility. What is the irreducible atlantoaxial dislocation? The etiology may be using improper reduction techniques. Actually, Atul Goel claims that all cases of basilar invagination can be reduced. Fusion of C1 arch and odontoid process can be a reason. Bony anomaly and contracted anterior soft tissues may be a reason. Previous surgery and failure, and position of the vertebral artery and occlusion in case of reduction can be the other reasons of irreducibility. If not reduced at all, odontoid resection may be applied. This is a common consensus on that subject. Then, what are the reduction techniques? There are many techniques actually. One of them is the preoperative cranial traction. Intraoperative traction under general anesthesia may be applied, especially in some groups. Posterior intraarticular release can be applied. Cantilever reduction and posterior occipitocervical fixation. Posterior osteotomy and transoral odontoidectomy and posterior occipitocervical fixation. Anterior release and posterior reduction techniques. And transoral atlantoaxial reduction plate or TARP operation and fixation. These are some of the reduction techniques used in the literature. If you look at the preoperative cranial traction, this is applied only in pediatric patients. And this paper from 2021 says that a two-stage approach, one is a Hello West, waiting 4 to 6 weeks, and then a CT scan was obtained. If a favorable reduction is achieved, then posterior arthrodesis was performed. Since a halo traction is quite long, halo loosening, pin infection, wound infection, CSF leakage, and delayed breakage are some complications of this approach. This is the pictures depicting application of halo and then reducing the atlantoaxial dislocation in a timely basis. What about intraoperative traction under general anesthesia? This is routinely done by some authors in addition to C1, C2 distraction and spacer cage insertion. Posterior intraarticular release is another technique. Goyal's technique is also well known and commonly used since 2004, and many irreducible cases can be reduced. And you can, at the end, you can place some graft or a cage or a spacer inside the joint, so that it provides a long-term reduction of the basilar invagination. What about cantilever reduction and posterior occipitocervical fixation? This may be done, according to the Guad and co-workers, by a pre-bent occipitocervical rod, which is designed according to the posterior occipitocervical angle, or POCA. Reduction without C1, C2 joint manipulation are also recommended. One is from 2014, placing screws on C2 and 3, jumping C1, C2 joints, and a reduction is achieved by an occiput C2 and C3 fixation. This is again without C1, C2 joint, again two-step reduction. One is the destruction between the occipitocervical junction of the rod and the occipital screws. Then the second step is the destruction between C2 screws and occipitocervical junction rod. Reduction without C1, C2 joint is by Shui and co-workers 2016. This is done by intraoperative manipulated occipital and C2 destruction and head backwards extension to achieve restoration. What about posterior osteotomy? This may be done by a posterior drilling and wedge osteotomy of the joint. Dr. Salunke and co-workers from 2018 has described that in pediatric patients especially. And then they concluded that although pediatric bones are soft and small, it is possible to achieve realignment by drilling and manipulation of C1, C2 joints. What about posterior osteotomy? Liu and co-workers have used a real osteotomy to release bone effusion of facet joints. And a specially designed rotating cutter was used to distract and prepare the facet joint space. In fact, this technique is not being used after introducing the Goyal's technique for basilar invagination. This is a historical technique. What about anterior release and posterior reduction? This is described in 2016 by Srivastava and co-workers. They have done in some patients with transferal approach and some other patients with retropharyngeal approach. And after reduction, they've done a posterior fixation. In most of them, occipitocervical fixation, and one patient, C1, C2 transarticular screw fixation. Anterior release and posterior reduction was done by two steps by Retot and co-workers. One is anterior retropharyngeal approach and insertion of a titanium cage ventrally, as you see here. And second step, occipitocervical fixation. What about TARP fixation? This is first designed by Yin and co-workers in 2004, a Chinese group, and they have done release, reduction, decompression, fixation, and fusion in one step with anterior-only approach. The advantage is it can move down the odontoid process from the foramen magnum and achieve reduction to directly relieve the compression anterior to the spine. This is one of the papers, again, Chinese group, applying TARP plates. And they have even compared TARP fixation with an occipital fixation, and they claim that the performance of reduction and decompression and earlier bone fusion with TARP procedure are superior to the occipital cervical fixation. This is Zhu and co-workers is similar technique, but some there are differences. Transoral intra-articular cage distraction and C-jaws fixation. They have done it in revision cases for buzzer invagination. So our old algorithm for buzzer invagination reduction was like this, reduced or not reduced, and then we were disseminating them in two groups. But nowadays, we can make just a posture fixation in reducible cases, but in irreducible cases, there are many different techniques, as you can see here. These statements are the consensus statements of spine committee of WFNS, saying that most cases of buzzer invagination and atlantoaxial instability can be treated by Goyen's technique of C1, C2 fixation, distraction of the atlantoaxial joint by a spacer or bone graft. Irreducibility criteria of atlantoaxial instability and cranial setting of the odontoid are not clear still. And preoperative or intraoperative cranial traction, drilling of facets and osteotomy, cantilever reduction and posterior occipital cervical fixation without C1, C2 joint manipulation, or anterior release followed with a posterior fixation, and transoral atlantoaxial reduction plate are some options to reduce the buzzer invagination. Current evidence is lacking which technique is better than the other. And there is still not enough papers comparing different techniques with the others. And there is no high quality study, even level 3 study comparing C1, C2 fixation with occiput C2 fixation. When extension to occiput is recommended, statement 3 is that in buzzer invagination patients, an occipital cervical fixation can be used in case of atlas assimilation, dyskinesis of C1 lateral mass, in irreducible cases, and if a transoral odontal resection was done. And this is our fourth recommendation, is that occipital cervical fixation may be preferred for revision of failed C1, C2 fixation. Thank you for listening to me, and then I invite you to come to Istanbul Spine Masters this October. I thank you for your attention.
Thank you for the lecture.
Okay, Professor, like always, you give very clever messages today for handle this difficult pathology. We are fortunate today that also later we can have the opportunity to see the concepts in the summary and in his conference of Dr. Atul Goel, who also with you, we can be very clever how is the real treatment for this pathology, like you show in the very nice summary in the new approach. Thank you. If you can think we can wait for the end of the session, we can make the question. For the next speaker from Russia, Dr. Vladimir Bibalsev, who is in the Department of Neurosurgery of the State Medical University in Russia, will be talk about it as the one topic who is not very common. We discussed it, but it's very interesting. Advantage of minimal invasive spine surgery technologies in professional athletics. Please, Dr. Vadim, welcome and thank you for being with us.
Thank you so much, dear colleagues. I'm glad to welcome everyone. It's great honor to speak on this conference, especially big thanks for my dear friend, Atul. Thank you so much for your invitation. And I would like to present to you experience of our experience of professional athletes treatment who had the lumbar spine degenerative disease. Minimal invasive spine surgery technology has been used for that. Professional athletes are a special group of the patient with a high level of the physical activity and significant motivation to return to previously functional activity as soon as possible after surgical intervention. Extreme biomechanical spine loads experienced by professional athletes while training or in the competitive contribute of the formation and the acceleration fusive of FSU degeneration processing, high amplitude flexion and extension, as well as extensive twisting lumbar spine movements are frequently accompanied by IVD hernias develop, deformities and segmental instability associated with persistent radical neurological manifestation require surgical treatment. 10 to 35% of professional athletes suffer from DDD symptomatic. Clinically significant lumbar degenerative disease is common for professional athletes. Its impact their lifestyle and blocks of way to the professional sport. Athletes' treatment require consideration of they return to the sport, while may involve in high energy impacts, sustained loads, repetitive stress, and prolonged walk-ups. These factors indicate the need to define diagnostic of therapeutic modalities to optimize long-term clinical outcomes. The lack of the treatment guideline of the spine surgeon motivate us to examine of our experience in the athlete treatment. The study purpose is evaluate of the result of surgical treatment for professional athletes with lumbar degenerative disease. There have been 235 professional athletes treated in Irkutsk Railway Hospital for 20 years. All athletes had 10 years experience of participation in regional and international competitions. Comprehensive conservative therapy was implemented for all patients. 53 cases showed clinical improvement. 114 athletes were included in a retrospective study. The following treatment was implemented, like microsurgical endoscopic discectomy, PRP, placenta-rich plasma therapy, total disc replacement, and lumbar interbody fusion. This slide demonstrates general informational and the preoperative study of the patient's data. The clinical outcome were analyzed, and the clinical and radiological data have been analyzed by using standard scale. Let's talk about microsurgical endoscopic discectomy, a group of professional athletes. We used classic microsurgical discectomy or spine tip endoscopy. Clinical case patient B, 26 years old, hockey player, and we perform this patient. The patient had the right side lumbar extraforaminal disc herniation L5S1, and we perform endoscopic discectomy with total remove herniation, and MRI 3 years after percutaneous endoscopic discectomy show no disc regeneration. His sport career, his safe position is the sport team, and this video of the patient training 3 years after percutaneous post-lateral endoscopic discectomy. The clinical case is professional basketball player. He had a poor result after isolate decompression. There is a preoperative MRI. You can see left side exclusion IVD, L5S1 with caudal migration. And this is a video demonstrate standard microsurgical discectomy with removed extrusion IVD mass. And after 3 years, patient returned to sport, but 6 months after operation, patient had the acute clinical signs of the S1 left side radiculopathy. And MRI, we see left side reherniation L5S1. The one level MI, the leaf revision surgery, patient had significant decrease of his clinical symptom, but he ended his sport career. So 12 weeks was a period of the time to return the professional sport in the group of this patient. Long-term result of the endoscopic and microsurgical discectomy shown high frequency, more than 50% of the cessation of the professional sports activity association with disc reherniation as postoperative segmental instability was not. Let's talk about PRP therapy in professional athletes. This slide shows stage of the PRP procedure standard. Clinical case, patient 28 years old, mountain scanner. And we registered bilateral facet syndrome, at the L3, L4 level with a degenerative change facet joint according to Fujiwara stage 2. And 2 years after surgery, patient has a regeneration of facet joint without any clinical manifestation. His sport career maintained position in the team sport. And this video on the patient training 2 years after PRP therapy. Please look at the down beautiful lake of the Baikal free zone. Three weeks was period of the time to return the professional sport of this group patient. There was no complication. Let's talk about use total disc replacement of the professional athletes. This slide shows stage of the lumbar total disc replacement procedure in our department. Clinical case, patient K, 23 years old, judoka. He had an excellent sports career before the operation. And FSU segment L5S1 saved the mobility as a right side disc herniation with minimal changes IVD and facet joint. And this demonstrate microsurgical disc removal L5S1 with total disc replacement. We usually return used micro, and you can see this is stage of the operation in our department. Postoperative flexion and extension X-ray, no signs of the instability and the function failure of the implant. Postoperative MRI, no signs degenerative disease of adjacent segment, and postoperative CT, no signs of the heterotopic ossification. And the patient continued her brilliant sports career and won various international tournaments. And this video of the patient training 5 years after lumbar disc total replacement. In 9 weeks after total disc replacement, all sportsmen returned to their career. Let's talk about lumbar interbody fusion of professional athletes. We used MI, ALIV, TLIF, and DLIF, dependent on the purpose of the surgery. Clinical case, this is a 31 years old football player. And MRI show the segmental stability of L4-L5 and cranial migration of L4-L5 disc herniation were registered. And this video shown MI TLIF with a reduced conflict disc with radix and stabilization procedure. And his career, no segmental instability. There was a 2 grade of the Breedwell classification fusion. This video demonstrate his training after 2 years operation. He continued his maintained career. And next case is this is a patient M, 36 years old, and he had the winner of the regional and all Russian competition winner. And look at the CT and MRI, segmental instability L3, L4, L4, L5, and combined stenosis were registered. And 3 years MI TLIF there were no signs of tegmental instability and adjacent segment, but in the L4, L5 had a pseudoarthrosis with a filar screw and pain syndrome prevalent of the patient from the high level sport activity, but he continued coaching the kids. 14 weeks was the period of the time to return of the professional sport of this group patient, but only one patient finished his professional career. In all cases, fusion group managing to save this professional career. Key point, minimal invasive technology helps significantly reduce on the level of the preoperative syndrome, pain syndrome, and the involvement of professional athletes in functional status. But some professional athletes face extreme changes to return to professional sports. And in all, multi-central researchers are highly required to create guidelines for effective neurosurgical treatments. I would like to thank my team and my patients. Thank you so much for inviting to me. Welcome to Baikal.
Okay, very interesting topics and very difficult with so much responsibility to try to help and recovery the activity that he was made before. For me, was a curious and also pleasure and share with you all this, but in special, the use of growth factors using in repair. In our experience in this department, who I am in this moment in Hospital Infantil Universitario of Colombia, we are using a specific growth factor for fibroblasts with fantastic efforts to the patient. I remember one who was has been in 2 months in one cervical disc, and he have and later to the Olympic Games and they silver medal or plate. So, and many soccer players, and I enjoyed, and it's nice to, we think how recovery, all these persons to be again in his activity. Thank you so much, Professor. Okay, the next talk is Professor Oscar Alves. For me, it's a pleasure to introduce him. He is from Portugal, from Porto. He is now co-chairman international of Academy of Spine and also chairman of neurosurgery in his hospital in Luciadas. Oscar has been for many years working very hard in spine, and always his presentation and his efforts in spine are very in the high level. It's for this reason his topic today about the vertebral artery managed in surgery for cervical spine show what kind of surgeon is him, and thank you and welcome, Oscar.
Good afternoon, here from Porto, Portugal. Tito, thank you so much for your kind words, and I have to praise Nasser. Nasser is really doing a great job for aggregating surgeons from all over the world. He's a great educator. Thank you also for Professor Goel for inviting me for this webinar. Actually, today is a bad day for me. I'm a kind of with the flu, but I will try to deliver a proper lecture and on the vertebral artery management in craniovertebral junction surgery. Learning is a lifetime experience, and I start to be interested in craniovertebral junction surgery when I work with Professor El-Ghandour as his assistant professor in the turning of the center in Paris. We did many collaborative work together. We have this brochure on the operative techniques in neurosurgery. Bernard George was my mentor and also a friend that I'm longing for him. When we're talking about craniovertebral junction, we are discussing mainly about V3 and V4. The V4 is the interdural part of the vertebral artery. The V3, the so-called extra spinal, is the portion that goes from C2 foramen to transverse foramen to the foramen magnum. And this is the sections of the vertebral artery that we are considering here today. As Professor Goel told us before, this is a very, very difficult area in terms of anatomy. There is a very intricate neurovascular anatomy, spinal cord, medulla, lower cranial nerves, the vessels. So a very solid knowledge of the surgical anatomy is needed before going to surgery. There was a concept evolution from being a no man's land to an expert's land, the craniovertebral junction. And certainly the sound knowledge of anatomy, cadaver dissections, carefully evaluation of preoperative imaging, planning and backup planning allowed us to become more experts on this surgery in this region. But no doubt, what allow us to do proper surgery with minimal morbidity was the control and mobilization of the vertebral artery in the craniovertebral junction. These are the traditional approaches, as Professor Zilelia told us, the transoral from an anterior perspective, the posterior midline, and what the lateral approaches brings us is a more different perspective, the anterolateral and the postlateral perspective. The key points of these lateral approaches is the mobilization of the vertebral artery, and as I will show you, minimal bone drilling that will preserve stability. So most of these operations, you don't need to do any stabilization. As I said, vertebral artery is the key anatomical element. Here you see the loops of the vertebral artery from a lateral view or from a posterior view. And we as surgeons, we can take advantage from the existence of these loops and mobilize the artery from the groove of C1 as here, or from the transverse foramen of C1. And you can mobilize posteriorly or upwards, and you can gain access to the pathology that otherwise would be impossible. Here it's the anterolateral perspective. We need to mobilize the vertebral artery because it is encased in the foramen, as you see here. And once you mobilize, you have control of the proximal and distal part of the vertebral artery, and you'll be able to control and operate safely. This is the posterior perspective from the posterior, posterolateral perspective. I will come to this later on. Why it seems also important to control the vertebral artery? The vertebral artery, when you're doing tumor surgery on this region, it's your enemy. And like in any war, you want to see the enemy at the first sight. You want to control the enemy. And I show you some examples of the location of the vertebral artery in cases of neurinoma. Here, the vertebral artery is located anteriorly. Here, the neurinoma pushed the vertebral artery posteriorly. So there is a variable location of vertebral artery in relation to tumor. So first, see the vertebral artery and control it. Is it difficult to work around the vertebral artery? Of course it is, you need training, but there is an anatomical characteristic of the vertebral artery that helps us a lot. And it's called the vertebral artery superiosteal sheath. The vertebral artery, you see here, is surrounded by a venous plexus, and both of them are enclosed by a continuous superiosteal sheath that it's continuous with the transverse foramen periosteum and the foramen magna dura. And the vertebral artery is free mobile within the superiosteal sheath. This is what allows you to do neck rotations and neck movement. So vertebral artery superiosteal dissection can be done without risk of injury. Of course, you expect some venous bleeding, but this can be easily solved with tamponade and waiting for a while. This is not craniovertebral junction, just a case of mine of a tumor in this area here, and you see how the vertebral artery could be nicely skeletonized and controlled to make the total removal of the tumor. Can you do all the time this? No. Sometimes vertebral artery periosteal sheath is invaded by tumor. And the classical example is osteocytosis. In this case, it's really difficult to go superiosteally to mobilize and control the vertebral artery. You can have also vertebral artery invaded by tumors like metastases, aneurysmal cysts. Also, you can do also iatrogenic lesions of the vertebral artery. And this author showed us that most of the lesions are done during decompression. As you see here, vertebral artery tends to run posteriorly when it descends on cervical spine. So it's a lot more vulnerable to C1, C2 surgery when you do it from the posterior side. And actually, posterior C1, C2 instrumentation has by far the highest prevalence of iatrogenic vertebral artery injury. And what are the points of concern? When you do, for example, simple surgery like the PRE surgery, and you are doing using unipolar cautery from medial to lateral, you have to remind that the vertebral artery is in the groove here. There is always a step here that can help you to identify the medial border of the vertebral artery. Also, when you do soft tissue dissection on the exposure of lateral occipital region, the vertebral artery can bulge also in this triangle. And of course, whenever you are working and trying to clear the area here for screw insertion, for example, on the lateral dorsal surface of C2, you can also encounter the vertebral artery. Here, just the bulge of the vertebral artery in the suboccipital triangle, and look how close the vertebral artery can be from the occipital bone. Here, a pseudoaneurysm from the use of unipolar cautery during midline dissection. Then the other thing you have to understand that there are a lot of vertebral artery variations and anomalies, like here extracranial C1, C2 origin of pica, or fenestrations of the vertebral artery. Look here, the extradural origin of pica. This can complicate your approach. It's on front of you. Fenestrations of the vertebral artery, as I showed before. Also, this is a very rich area for bone anomalies of embryonic origin. So whenever you have this kind of bone anomalies, you should highly suspect of modified course of the vertebral artery, like atlas assimilation, atlasoplasia. This not only faces anatomical landmarks, but can also modify the fixation constructs. Of course, rheumatoid arthritis, it can also efface your surgical landmark. You have to be careful of that. Sometimes you need intraoperative navigation with intraoperative angio, find really where the vertebral artery is. So coming back to our anterolateral and posterolateral, I tend to use anterolateral for extradural anterolateral tumors and the posterolateral approach for all my intradural tumors and extradural posterolateral tumors. This is kind of the concept, the general rule. Intradural tumors, you can have a lot of different types. Most prevalent are meningiomas, only 4% are extradural, and the second one are melanomas, and 38% can be extradural. Then epidermoid, melanoma, angioblastoma, epinema. So this is our classical midline approach that I was trained on, and you see that the window here is really small. This is what you can do. But if you mobilize the vertebral artery from the groove, you dissect to periosteally, you elevate the vertebral artery, you can enlarge a lot the angle of your exposure. So the transposition of vertebral artery from C1 groove allows a much wider exposure. Pay attention that there is a variation in the height and the extent of this groove of the vertebral artery. Sometimes can be more medial, sometimes more lateral. Here you have the vertebral artery entering the dura below C1. So be careful with that when you are dissecting here. Another very important concept on this area and on the posterolateral approach is that you hardly need to do a lot of condyle drilling or instrumentation when you dealing with intradural tumors. And why? As I draw this line here, you see that the posterior line that connects the posterior part of the joints is all anterior to the neuroaxis. So the neuroaxis is posterior to the C0, C1 joint. This is not the case in subaxial spine. So if you consider that a tumor, even an anterior located tumor, pushes the spinal cord posteriorly, you have a very nice chance of removing all the tumor without needing to drill the condyle and to instrument the patient. Of course, the extent of lateral drilling is dictated by the location of the tumor. After you have done all your bone work, you do a country incision, you open like this kind of incision, a C incision, and the country incision to the entry point, the dural entry point of the vertebral artery. Then there are three things that can happen. Either the tumor is below the vertebral artery, above the vertebral artery, on both sides of the vertebral artery. Is this important? Yes. If the tumor is all below the vertebral artery, all the cranial nerves will be displaced superiorly, away from the tumor. And this will make your life much easier. When the tumor is above the vertebral artery or above and below, the location of cranial nerve is unpredictable. So a lot of debulking has to be done, control the capsule, alternate debulking with dissection around the capsule. As I said, lateral drilling, it's important to expose more lateral tumors, or if you're doing it with an anterior tumor, you probably have to go on both sides and work on both sides. This is just a small series of mine, and completely sectioned in 100% patients, no surgical mortality, the number of CSF fistula, and only 2 patients that deteriorated after surgery. And these are some of the cases. We'll go very quickly through it. Pre and post-operative. Now let's go and have a look on the anterolateral approach. This is the position in your arm, single supine position, 10 degrees of rotation. Don't do much head rotation, because this will take the anterior arch of C1 away from your surgical pathway. A cushion under the shoulder. This is the incision along the sternocleidoid muscle, crossing here the tip of the mastoid. It can be prolonged upwards if you need to do any form of intracranial work. Be aware that, sorry, whenever you do a rotation of the head, like here, even 10 degrees, you always have some rotation of C1 over C2, and this will bring the relation of the vertebral artery is completely different. From a bayonet shape, it comes to a U kind of shape. And this is, of course, to preserve the blood flow. So the course of vertebral artery and anatomical relationship changes during at positioning. So open the field, the surgical field between the CSM muscle and the internal jugular vein. If you do it lower in cervical spine, there is nothing cross. Upwards, you have the accessory nerve that you have to isolate. You just test it with neuromonitoring. It's always embedded on the fatty sheet that you can wrap around the nerve to protect it. The next step would be the resection of the muscles inserted on the C1 transverse process, exposing the vertebral artery, and you do an unroofing of the C1 transverse process. As you see here, this is in a cadaver, this is in a patient, and then you'll be able to mobilize the vertebral artery. Transposition of the vertebral artery, as you see here, bringing the vertebral artery backwards, and then this exposes all the lateral wall of the foramen magnum, even up to the jugular tubercle. This is a case of C2 urinoma, mobilization of the accessory nerve here, the jugular vein, and this allows us to remove. Case of C2 osteoblastoma, previous control of the vertebral artery. So very, very briefly, this is relating to tumor surgery, but when it comes to instrumentation, your C1 screw here is really close to the entry point of the screw to the vertebral artery. So this is one of my cases, intraoperative imaging, no bleed at all, control the bleeding, add elevation, coagulation, packing with hemostatic agents if you need. This will make everything clear to avoid problems. This is a broad ponticulus posticus that can mistake you for the insertion of a C1 pedicle screw. Be careful of that. Also, when I do C2 pairs of pedicle screws, always tend to do a rather superior and medial entry point to avoid the vertebral artery, and therefore more superior and medial trajectory to avoid damaging the vertebral artery and palpating the medial wall of the C2 pedicle. Just some of our cases here. Look how I like to operate. These patients, they don't need to lose blood. You can do one of these operations in less than 50 ml bleeding. Case here also with also the pedium. Here, I think we risk too much. Vertebral artery was really close, but we were able to insert a screw. Be aware that almost 25% of patients, it's not possible to insert a C2 pedicle screw. You need to do fine cut CT scans in all patients prior to surgery, and if you have it available, consider CT navigation. And why is that? Because there's a decrease of less than 5 millimeters of isthmus height, and the internal height also of the lateral mass is smaller than 2 millimeters. This happens because of this high and medial right vertebral artery that really makes it impossible to pass a screw here. Different relationships between the pedicles anatomy and the right of the vertebral artery that you have to be aware before you do your surgery on your patient. So vertebral artery really equal size only in 40% of patients, being both very small, it's very uncommon. Whenever you are inserting a screw, always start on the side of the safest trajectory. If vertebral artery injury occurs, do not insert a contralateral screw. You can use a translaminar screw, for example, which makes your life easier. You don't risk much, and this is the case of a translaminar screw, as you see here. I learned also this technique from Professor Google. This is one of his cases. Whenever you cannot pass you cannot find your entry point for C2, you can skeletonize the vertebral artery and mobilize it. And this is one of our patients with Down syndrome that we have done something similar. Vertebral artery, this is the spinous process of C2. We have a cage in C1, C2, and this is the entry point of the C2 screw, and the vertebral artery was skeletonized in here. So, for conclusion, vertebral artery mobilization is technically challenging, and it's something you need to do to know and be able to master it if you want to do craniovertebral junction surgery with tumors or even instrumentation. So careful preoperative planning, accounting for all the vascular anomalies and anatomy is mandatory. Learn this technique of supraosseous dissection that will allow a safe mobilization of the vertebral artery. And when doing with tumors, mobilization and control of the vertebral artery proximal and distal to the lesion is really the key step. And be aware that aberrant vessel location may inhibit safe spinal instrumentation. Thank you. And this was the last time I was with Professor George on the cadaver lab in Liège in 2018. Thank you so much for your attention.
Thank you, Dr. Oscar. And now we are conclusion, the first step of this webinar with these 3 interns conference. I will ask if some of you want to make some comments briefly, because we are 5 minutes late, but I want to say hello again to all of us. And Oscar, excuse me, we grow together. I was so happy for 2 reasons. Dr. Goel says something that is important. This is difficult area. This is one pathology who we are not improving because we was before afraid to see. But when you look the anatomy, when you see the really issues, like you show, how are doing the artery that's supposed to be here and is in the other place, today we are available to see with the trajectory. Also, with many advance of all this kind of technology. For this reason, also, I would like to emphasize one thing that maybe looks not nice for many people. We are neurosurgeons. We are training. We take tumors of the skull base. And one people who don't use microscope and try to go to put in to a force screw there. Today, we can be in our minds, and we have to all technology for make safe to the patients. And if you have, if any of you have another comments, welcome.
Yeah, Tito, thank you for your words. It's exactly that. I think all of this is related with understanding the anatomy and having the proper training. Of course, this is not a surgery for everybody, but with proper surgical technique, with, as you say, with microscope, with the navigation, with all sorts of tools that we have been awarded over the last years, it's possible to do this technique very, very safely. And you have to learn with the masters. That's the pathway.
Okay, Dr. Nasser, Dr. Atun. Okay, we have continued to the second section. Now we have the talk of Dr. Virendra Shinna. He is from India, and he will be speak about the using of three-dimensional printed models for making the operations more safe. Dr. Signa is an actual member of the Asian Association Neurological Surgeon, who is a general secretary, and also was a past chairman of the Committee of Neurorehabilitation, and also is member of the Neurotrauma Committee. And Dr. Signa, it's nice you be here with us, and especially because I know next week we will meet probably in Ikran in Bolivia. Welcome, Professor Signa.
Thank you. First, can you hear me?
Yes, yes. Yes.
So first, I want to thank Dr. Nazar and Atul for inviting me for this very excellent webinar. And I want to compliment Dr. Nazar for hosting such a series of webinars with high academic contents. So my topic of presentation is CV junction surgery using 3D printed models. We all understand the surgery of CV junction anomaly is difficult and high level skill and expertise because we work in very narrow space. It is not under our control sometime, and we work under the CR. Abnormal anatomy and course of the vertebral artery when it is abnormal make more difficult and complicate the things. CV junction is itself a very complex anatomy, and the pathology makes more complex this. And we work near the vertebral artery, spinal cord, brainstem, and lower cranial nerves. And we know that we use such a high drill instruments and sharp instruments, so it is always fear of injuring the number of or the vital structures in this region. So I want to tell how I started this technique in Rome in 2015 when I was chairing the session of 3D. So that time I decided that it will be always better if one can have rehearsal or procedure a day before the actual surgery, so we understand better the anatomy outside of that region. So, and definitely it is possible with customized 3D printing model of desired region. And if we compare with the 3D generated computer images, it is much better, these models, for the understanding the anatomy. And vertebral artery in these models can be delineated very nicely, and number of times we can have much better understanding and how safety of this vertebral artery. And important thing, we can have a practice or rehearsal about this on these models, and the lamina, pedicle, and all these things can be better understand for surgery. Cadaver dissection is very important, but it does not predefine pathology. So it is definitely 3D customized model is better option for all our patients who go for the CV junction surgery, we go for the 3D CT scan. The DICOM images we change to STL format, and it goes to workstation where the PLA or ABS material used to make the customized 3D models. In say from 16 to 21, we operated about 51 cases, and now we added 10 more. And all the patients of CV junction and sometimes C1, C2 fracture also included. We include the investigation MRI, dynamic CT sometime, and making 3D model of CV junction with vertebrality. It is in all the patients. The clinical outcome we judge with GOS score, and pre and post operative craniometric indices we use in all the cases to assess the displacement of the anomalies. So they are the different lines, craniometrics we use in all the cases. I know everybody understand this. So in this study, our aim was that 3D model of patient is looked for your orientation of C1, C2 facet surface and degree of dislocation for better understanding. Thickness of the C2 pedicle lamina also noted. Vertebral course is not abnormal or normal, we can know, and whether C1, C2 joint can be approached or not, we can understand better with this customized model. So we do exercise a day before the actual surgery. So in the model, joint surface were drilled, C1, C2 screw were noted, and screw was put without residual control, and the C1, C2, this all structure we assess. So this is just a preoperative exercise. This is our model, and this is the vertebral artery delineation here, very well delineated. This is the C1 joints are drilled, and this is after rehearsal C1, C2 fixation done with rod, and this is all the cases we did a day before. So we have two studies. In first study, we were having 21 cases, 16 cases of AD and BI, and 5 cases of the C2 fracture. So in all the cases, in the model, the 3D customized model, the C1, C2 fixation done. But if we think that is not possible to drill C1, C2 fixation, then this is plan B. This is plan A, this is plan B. Occiput and C2 was fixed. And in number of cases, we were assessing better before surgery about the A or B plan. So in all the cases, the operative traction and this is position of the patient during surgery, Professor Atul Goel position, and I want to compliment Dr. Atul Goel for a lot of contribution, the CV junction, and post-operatively we keep the patient in hard collar. So I want to just share few of my cases. This is AD and BI, you can very well see here. In all cases, MRI and CT is done. And here we plan C1, C2 pedicle fixation with bone graft in this joint. So this is the model mold which we customized mold before surgery. So it was showing hypoplastic vertebral artery on the right side. So this is post-op, just good reduction of the AD and BI also reduced, and all the screw they are in position and patient improved. This is another case of AD, you can see here, and here this is the mold. We are showing the vertebral artery just crossing the right C1, this joint, C1, C2 joint. And we planned C1, C2 fixation with spacer. So just to confirm the artery, we went for the this angiography, and it is also showing the vertebral artery just passing through the C1, C2 joint. You can compare both sides, it's reconfirmed. So before surgery, because this mold and this angiogram, we decided to mobilization of the artery, and the mobilization of the artery is very well told by the Dr. Oscar. And this is just a small video. Want to show. So we could identify the artery and subperiosteal, as he says. Yes, he's right. And we are mobilizing it. And after good mobilization, we just open the joint and after joint open, we put the spacer. We put the spacer, and just this is post-operative. Just show good reduction of AD, and patient was preserved and improved and discharged without any problem. This is another patient of AD and BI. Just here we plan the occipit C2 C3 fixation. This mold shows that that was occipit and C1 was fused, and it was not possible to put the screws here. And this is the pre-op, and this is post-op CT showing good reduction. This is another patient of AD and BI. Here we plan C1 C2 joint fixation, and this is the deficit of the C1 arch here, and this is the pre-op CT scan showing the AD and BI. So just this is post-op showing good reduction, and visual invasion also improved, and everything was very well delineated on the customized mold. So we are knowing about the during surgery what is going to happen and what are the steps. This is AD and BI. This is AD and BI both, and so this is a foramina very compromised. So here we plan the foramina decompression and C2 and occipit fixation. So here we were knowing with this, because of this mold, that's C1 C2 joint, and we cannot assess here. So we plan this occipit C2 fixation with C1 and foramina magnum decompression. This is a post-op CT scan showing good fixation, screw there in place, and good area here, and no compression, patient improved. This is another patient of AD with BI here. So we plan C1 C2 joint the fixation, and this is the mold. There was anterior segment was floating, so which we couldn't see the mold. So this is the post-op CT and showing the C1 screw in place, but in C2 there was variation of the artery, so we put just that translaminar screw here. This is another patient with AD with osteodermium. See AD with osteodermium, and here we plan C1 C2 fixation, and this is the good reduction here we could see, and patient improved. This all work was published, and this is just brief about our patient summary. Now I will talk about the traumatic C2 fractures. So there were 5 in number C2 fracture. In one patient there were AD with C2 C3 dislocation. So just see, this is C2 body fracture, and we plan C1 C2 fixation and spacer in the joint, and this is the fracture. Here we can see in the mold, mold, and that the screw were placed, they were in position, and in all the cases we did real cell 8 day before. This is another patient of C2 fracture. Again, we plan C1 lateral mass and C2 pedicle and rod fixation, and this is the fracture here we can see, and the screw are in all position. This is another patient of AD with C2 and 3 dislocation. This is where X-ray is not very good, but we can see that AD and this dislocation here. And in the mold, we did the real cell, and we did the C1, C2, and C3 fixation before surgery, and So we were knowing all the structures and problem during surgery, and this is just post-op CT showing all the screw in position, and see good reduction. Although C2, C3, there was satisfactory reduction, and but patient improved after surgery. So every operation has complication also. So we had a hypoesthesia in 4 cases, occipital pressure sore in 2 cases, and no mal-displacement of the screw were seen, and no vertebral artery injury. But in second series of our study, 20 cases, we had one mortality because during destruction, we had a vertebral artery spasm, and post-op patient has brain stem problems, and patient was taken on ventilator, and patient finally, we lost this patient. So our experience says that 3D printing model is exactly same as of patient anatomy, and it help in better understanding of the complex anatomy in this region. And small surgeons are very confident. We are much familiar with the important structure landmarks in the patient, and screw malplacement incidence is about 8%, but as per him, 32%. And when we compare with 3D printed model, malplacement was 2/3 less. So it is a good decrease in the malplacement screws. This is a very good study we did first time. So all the vertebral artery we just delineated on the mold, and we found that we were much more wiser or confident about the placement of the screw during the surgery because of this study or mold beforehand. So we can know the distance of this artery from the joint by the malleable wire. We are measuring, and if in 2 cases we notice hypoplastic artery, so we place the screw on the hypoplastic artery side, and later, if it was successful without problem, then we put on the other side. So as I told or mentioned before also, that if C1, C2 fixation was not possible, then we change our plan from plan A to plan B, occipit and C2 fixation. And length of screw, contour of rod, and preoperatively we were knowing, so it saved our time and blood loss as well. Every technique has a disadvantage also, like 3D printing model, there is absence of soft tissue in the model, and the moment during the surgery, which we can't assess in this customized mold. So these are few disadvantages, and floating segment we can't see in the customized mold. So just I want to conclude that 3D printed molds of patient to practice surgical procedure can be of immense importance in CV junction surgery, and it can be practiced by young surgeon also. Then it is good for technique for teaching and demonstration of surgical steps. Thank you very much. There are a few of my patients who benefited by this technique. Thank you. Same nice of you. Thanks.
Thank you so much. Thank you. Very nice talk before of the talk of the Professor El-Ghandour, because made the illustration how today we can planning everything before and
Yes.
go straight ahead to performance surgery. And our next speaker is Professor El-Ghandour, who, in my opinion, is the new father of this kind of treatment in cervical junctions. And to fix this pathology, how you say is a new father? because he's bring to us, with all his experience, new concept, and may really be putting his finger in the issue of how you solve the physiopathology. So for me, real is a great pleasure that have him here, and I hope many of us will be learn again more and more from him. So, Professor Atun, thank you again for being a teacher, for being a creator of the new think about how we handle this difficult pathology, and we will that you say in your talk introduction of the new concept Atun. Please, Dr. Atun, it's your turn.
I think Dr. Atul is not here.
It's not here? Okay, so,
I think it was kept last.
okay.
Dr. Nasser will give better information.
Atul, he is just for 50 minutes. He will join again, and so we can move to next speaker until Atul comes back.
I see there are another speaker, Dr. Thomas. Are you here? Professor Thomas?
And I'm unmuted. Yes, I'm here.
Okay, I will invite you to the next interest talk that is basilar imagination, and Professor Nick Thomas from UK, and also he's working for many years in this topic, and also will be introduced as the radiological variation in this basilar imagination depends of the geographic area. So please, Professor Thomas, thank you for being here, and you can start.
Thank you. I'm just trying to share screen. Let's see. Can you see that?
Yes.
Lovely.
Yes, sir. Yes, sir.
I am working. Excellent.
It's good. Thank you.
That's the first hurdle reached. Thank you very much indeed. Professor Perea, thank you very much indeed for the invitation to speak, and thank you, Professor El-Ghandour and Professor Gold, for organizing this meeting.
Thank you.
My talk is basilar imagination, and are there geographical variations in the pathology? Just as a background, I trained in London at the Atkinson Morley's Hospital, Queen Square, Great Ormond Street, and did a complex spine surgery fellowship at Ohio State University in the 90s. And it was while I was at Queen Square that I came across Alan Crockard and became interested in craniovertebral junction surgery. And since my appointment at King's College Hospital in South London in 1998, I have had subspecialty interests in open and endoscopic skull-based surgery, pituitary, and complex spine, concentrating on the craniovertebral junction. And back in the 90s, we'll all be very familiar with the fact that the odontoidectomy was commonly performed with rheumatoid arthritis, a disease which is now exceptionally well medically managed without the need for surgical intervention. And also over the years, TB, chordoma, chondrosarcoma, metastatic disease has been part of my practice for the trans-oral or transnasal odontodectomy. And also since being a senior resident back in the mid-90s, I've done voluntary work in Sri Lanka and have exposure to the sorts of disease processes that involve the craniovertebral junction that is familiar to the Asian surgeons. Just one of the other points that we have here in the United Kingdom is that we have an overarching body, the NHS England, and what that aims to do is to standardize high quality care across the country. And what has been recently identified in the last year or so is what is called low volume, high complexity disease processes. And of particular relevance to ourselves as neurosurgeons is chordomarochondrosarcoma surgery and odontodectomy, perhaps explaining a little bit about the lack of understanding of NHS England. They didn't call it basilar invagination, but odontodectomy. But nonetheless, what it does mean is that out of the 24 neurosurgical units that we have in England, at some point, a number of specialized units will be identified to perform these sorts of operations such that there is adequate experience for these disease processes. And of course, having dedicated conferences like this is absolutely essential to ensure that the surgeons that are involved in these conditions are familiar with what is going on in different countries and across the world. So we're all very familiar with the wide geographical differences in prevalence of basilar invagination, and in the Western world, it is very much more uncommon. And over my last 24 years, I have done 24 odontodectomies for basilar invagination or impression. And many years ago, when I first started off as a consultant, this was performing a transoral approach. And since 2007, I've converted to the transnasal approach with the endoscope. And so I'd like to give you a little talk through the journey of how I have modified my treatment for these sorts of patients, and perhaps how it differs somewhat to what we have seen certainly in the previous talk in India, where the odontodectomy is not a common procedure. The distraction techniques posteriorly seem to be very effective. And indeed, well aware that Professor Goel will say that an odontodectomy is a very uncommon maneuver required for the management of his patients. We're familiar with the concepts of basilar invagination, where at the C1-2 joint, there may very well be instability. There, broadly speaking, dimensions that are documented for the adult and the pediatric population that vary from publication to publication, but ultimately there can be neural compression by the odontoid peg. There can be migration rostrally. And as a result of this instability, there may be what are described as chronic natural alterations in terms of clipple file, assimilation of the atlas to the foramen magnum, C2-3 fusion, the ossodontoderm, platybasia, and Chiari. And I suppose one of the questions that would be one that I would ask the experts is how long does this chronic process actually take? Because as you will see, I have a number of pediatric patients where even at a very young age, the clipple file has developed, assimilation of the atlas has, and the instability or the mobility at C1-2 seems to be less in a number of my patients than that might be in the Asian population. And reduction is very much more difficult. Nonetheless, preoperative imaging should be performed to see if there is any evidence of instability, be it type 1 or type 2, according to the Gold classification, and whether there is any atlantodental distance increase. We've had a very nice paper already and presentation indicating that CT imaging through the craniovertebral junction needs to be performed to see the suitability of any fixation, and on occasions the pedicles will simply not take a pedicle screw, and an alternative way of fixing the craniovertebral junction needs to be sought. Again, we will all appreciate the classifications from Professor Goel, but ultimately, irrespective of whether this is a patient that has a group A or a group B abnormality, where the tip will vary in terms of its position relating to Chamberlain's, McRae's and Wackenheim's line, there is a degree of atlantoaxial instability, which I understand to his mind will mean that there is an ability to pull these patients out with traction with a posterior C12 cage compression posteriorly and flipping the odontoid forwards, thereby negating the need for any odontoidectomy. So when we look at the multiple lines, the line that I've chosen to most accurately reflect where the odontoid peg is in the patient population I have is McGregor's line, extending from the posterior aspect of the hard palate to the base of the occiput posteriorly. And the technique that is promoted by Professor Goel and others of traction that has to be really quite intense, perhaps prolonged and with heavy weights, joint jamming with a cage, thereby reducing the rostral odontoid migration, compressing a posterior construct, and therefore by negating the requirement of an odontodectomy, is something that I will still try. On the right, this is a picture of a patient with a Chiari malformation, because on many, many occasions, despite my efforts to mobilize this joint, even with disarticulation at C12 with removal of the soft tissue within the joint, I found it very difficult. And so this practice of trying to get rid of the odontoid's rostral compression is not something in the population of patients that I have, I've managed to succeed to do. And a very nice set of images indicating exactly what was demonstrated in the previous presentation that allows the odontoid to be disimpacted from the foramen magnum and flip forwards away from the spinal cord. Is something that I've not seen to be possible in the patients that I have. Clearly, if there is gross atlantoaxial instability, this is a patient with epiphyseal disease, Walcott-Rallison syndrome, then distraction here is possible. The patient has an osteodontodem but does not have basilar invagination, but could be distracted easily, and that the foramen magnum opened up satisfactorily and the patient's spinal cord decompressed. So what is the algorithm that I would have for my patients? Well, it would be the same as it would be, as has been discussed before. The patients are offered traction, but out of the patients that I've had, they've all declined. And I perhaps suggest that this may very well be a cultural thing from patients in this country, but young age, learning difficulties, a patient who was anorexic and bulimic and vomiting a lot and said she wasn't able to cope with traction, or patients with previous fixation are all reasons why I've not been able to offer traction. And while I will do a posterior exposure intraoperative distraction with a C12 joint release, I've not had as a primary treatment for basilar invagination success that has been described by many others. And the posterior occipitocervical or C12 fixation will be performed if stability is to be compromised. And my approach now is a transnasal endoscopic odontoidectomy. So when I hear talks like I have previously, and perhaps when Professor Goel speaks, I wonder sometimes whether I should rename my talk basilar invagination. Am I trying hard enough? And I will have to pursue many of the techniques that are espoused in terms of trying to avoid an odontodectomy. This is an incomplete set of data of my patients over the last 20 years. The first 6 patients were ones that I'd operated upon in the National Hospital, Colombo, Sri Lanka, more than 20 years ago, all with a transoral. There was one patient with a mandibulotomy and a transoral who had Klippel-Feil trismus and was severely autistic. And then more latterly, they're all transnasal odontodectomies. But what you will see on the right is a patient with osteopenia. He had social care issues. He had malnourishment for years. He was under the care of a pediatric hospital, but you can see a grossly deformed clivus with the tip of the clivus actually disarticulated from the main body of the clivus, and rostral migration well above the hard palate. So more than 20 years ago, in a child of 16 with Klippel-Feil basilar invagination who had been pillow fighting with his brother and then fallen on the ground and was transiently quadriparetic, but also had severe trismus such that he wasn't able to open his mouth very well. This patient underwent an odontodectomy, but with a mandibulotomy simply because I couldn't access the back of his pharynx via a standard transoral. And over time, of course, we've not only modified our approach to be more minimal access, but our constructs have become very much more advanced from what you see there from 2002. So mid-sagittal approaches for an endoscopic surgeon would standardly be for the pituitary, but anywhere along the anterior fossa floor, clivus, and to the odontoid. And this, of course, is a very attractive approach for basilar invagination, particularly with the rostral migration of some of these odontoids being so high that transoral is technically rather demanding. So here is the 9-year-old child whose images I showed you before, with severe clival and odontoid compression of the brainstem and the upper cervical spine and a significant syrinx. He was severely myelopathic by the time he came in. This is a true case of basilar impression with bone softening and demanding drilling of more rostral bone. You can see the angle that I'm heading at with a drill between the two carotid limbs underneath the pituitary fossa all the way to the top of the clivus. And one of the aspects that I've learned about these operations is that when one is doing the odontoidectomy, you are protected to a considerable degree by the cruciate ligament and the posterior longitudinal ligament. So the chances of getting a cerebrospinal fluid leak are actually relatively low. Whereas if you are trying to drill out the clivus, what you find right behind that is dura without ligament behind it. And the risks of causing a CSF leak are very much greater. And one has to be extraordinarily careful in avoiding that, because these can be difficult leaks to stop. But you can see there the bone being drilled out satisfactorily, and the C1-2 complex in this particular case wasn't compromised, so I didn't do a posterior C1-2 fixation, with the stability of the transverse ligament being maintained intact. And of course, you can see there with the standard transoral approach, this would be difficult to reach. Basilar invagination, we understand, relates to premature fusion of sutures occipital hyperplasia and the telescoping of the odontoid into the foramen magnum. And again, with a transnasal approach, one can approach this satisfactorily. This patient had a posterior fixation done by me. I attempted to distract the odontoid from the foramen magnum, but without success. So I then turned the patient over and performed the odontodectomy, on this occasion using an ultrasonic aspirator with a side angled tip, which means that you can then dissect parallel to the dura rather than drilling towards it, which I think increases the safety profile of the dissection and mitigates the risk of developing a CSF leak. And you can see the dura there pulsating satisfactorily, indicating that, again, with the removal of portion of the clivus and the odontoid, that there is good decompression of the craniovertebral junction. This is a patient who had undergone a C1 laminectomy for his basilar invagination by another surgeon, and within a few weeks became profoundly quadriparetic. And perhaps one of the limitations that I always think about, without the traction, which again was declined by the family, that even if you remove all of the odontoid, you can find that there may still be a portion of the body of C2 that is impinging a little bit against the neural structures at the craniovertebral junction. So in the bottom right-hand corner, you can see that the odontoid has been taken all the way down to the body of C2. And despite the fact that the patient clinically has actually done very well, I look at the pictures in the top right and wonder whether I would have preferred a little bit more removal of bone posteriorly on that C2 vertebral body, or a little bit more decompression of the neural elements. This is a 21-year-old lady who presented 2.5 years ago. She's got a reasonable range of mobility of her neck. She doesn't have a hypermobility syndrome, but she's 6'1". She's anorexic and presented with left-sided weakness and sensory changes. And here are her MR and CT images. You can see she's got a remarkably long neck, such that you'd probably be able to do a T3, T4 ACD in her. Quite dramatic appearances. And again, we counseled her with respect to traction before the operation, but she declined. She has already got assimilation of C1. She's got clipper file, and she had an uneventful odontodectomy and a posterior fixation. And again, an attempt at the time to distract posteriorly was unsuccessful, but more to the point, you can see that her C1-2 joint is almost vertical. So the idea of being able to satisfactorily distract and maintain the odontoid in a reduced position, I think would be very, very difficult indeed. And she was managed at the beginning of the pandemic, and all seemed well. Her neurological symptoms improved, and she went away not to return until about 3 weeks ago, when she presented back in A&E with altered voice, nasogastric feeding. And she's the only patient that I've had come back with worsening symptoms. And so this is what she was like. So just over 2 years later, she had velopalatal insufficiency. So she was regurgitating fluids through her nose. She was nasogastrically fed. She had an altered voice, and interestingly, no worsening myelopathy, but she also had construct failure. And so she's the one patient that I've had in this series where there is a requirement for revision surgery, which I performed last week. And what was apparent now was that she was very mobile, and I then did manage to intraoperatively distract her because, again, she declined preoperative traction, and I fixed her down to C5 on this occasion, and she's doing well. She's having speech and language therapy. She still does have some velopalatal insufficiency, but interestingly, immediately after the operation, her voice went back to normal. So quite clearly, her upper airway structures had been satisfactorily repositioned. Certainly, she's got much better alignment, but still a little bit more work to do on her to get her fully better. The transnasal approach can be time-consuming. Most people will now describe essentially cutting out a block of the pharyngeal wall rather than flaps, which have a high chance of failing and simply need to be resected afterwards. You can see here exposure of the sphenoid sinus. The basopharyngeal fascia has been removed from the clivus, and then bone exposed once the posterior pharyngeal wall has been removed for the odontoidectomy. It's time consuming, but it can be very effective. And apart from that last patient with her velopalatal insufficiency, I've not had any other patients who've had problems. The pharyngeal wall seems to fill in extraordinarily well. I put a bit of tisiel in there, and it scars over without any great consequence. So in conclusion, I found it rare to have C1-2 instability that's amenable to the joint jamming and tipping procedures that have been espoused. The endoscopic approaches certainly have significantly reduced morbidity in comparison with the transoral approach. And in my practice, I found that odontodectomy remains a common treatment. And I feel that I continue to learn to see if I can reduce my requirements for this part of the procedure. Thank you very much indeed for your attention, and thank you again for the invitation to speak.
Thank you, Professor Thomas. Very nice and important concept, and really with your experience are to show what is the development until this time and how we can manage it and solve this difficult problem. Also, at the less techniques by endoscopic that in the future we trying promise be more easy and helpful in the case that you need to remove the odontoids. Thank you so much for sharing with us with your experience.
Thank you.
Now, I don't know if Dr. Goel is here. If the other, in other case, we can.
Tito, I'm here.
Okay, Professor. Thank you. I introduced you a couple minutes before before Dr. Thomas, but maybe you was like me sometimes in doing some physiological issues. But really, the most people, we have to tell the truth, you know me. Most of the people are here in this webinar for know about your new concept of a tool, because I said before that you, in my honest opinion, you are the father of the new view and approach for cervical junctions treatment. You are reviewing the physiopathology. You are introduced very easy techniques that for sure will be more easy the surgery, that Dr. Thomas tell us before, and all previous speaker, going also, Dr. Mehmet also tell us that the best thing is when you are doing simple, right, and according to the anatomical principle. We will do, and then last moment, answer the question, because we have in this moment around 10 questions from the all speaker, and permit is our pleasure. And thank you so much for tell you, and you have the time because other speaker doesn't come. You have a little more time that you wishes for tell us. And please go ahead.
And you see my slide, Tito?
Yes, sir. Yes.
Okay. So I am going to discuss a new dimension to spine surgery. Completely different concept of spine surgery. If you really ask me, in spine surgery, there is one issue. That issue is compression, and the treatment is decompression. That is spine surgery. Compression is the issue, decompression is the treatment. So I'm going to go beyond it. So I have talked about this subject for several times. Tito, you have heard me. Nasser, you have heard me. But still, I want to talk again. Human body is different. Human body is different from animals, from birds, because we are standing position, standing human body. All the muscles of the bird which make the bird fly are focused on the shoulders. All the muscles of four-legged animals are on the shoulders and on the hips. But all the muscles of human body are focused on the spine. My concept is very clear. The weakness of muscles of the nape of neck and weakness of the muscles of the spine is the issue in spinal problems. I also wish to introduce a new concept of vertical facetal instability. And I have said in my articles that this is where the spondylosis begins, degeneration of spine begins, when there is facetal instability due to muscle weakness. I wish to introduce, Nasser, in this webinar, a very fantastic new concept, which is different. Compression is never primary. Compression is never an issue. Compression is secondary. Compression is protective, and compression is reversible. And decompression is never a treatment. So this is a different version of spine surgery, which I am going to present before you. First, I am going to talk on craniovertebral junction, like we see Chiari with syrinx, Chiari with syringomyelia and syringobulbia with little bit facetal instability, basilar invagination with syrinx and Chiari, basilar invagination with Chiari with big syrinx, atlantoaxial instability with Chiari, Chiari and syrinx without atlantoaxial instability with no bone problem. My question before all of you is, are these different problems? Is the treatment different in all these issues? My answer is no. They are one problem with different manifestation, one problem with different phases. Atlantoaxial instability of chronic kind. Acute instability is one. Chronic. When there is chronic instability, there are many secondary issues which are all protective, which are all natural, which are all adaptive, like Chiari, basilar invagination, shortening of neck, torticollis, platybacia. All these issues are secondary They are not pathological as we have learned to see them. They are all reversible after atlantoaxial instability. So atlantoaxial instability is a huge thing. Atlantoaxial joint is the most mobile joint of the body. Atlantoaxial instability is the most common form of instability in the spine. And chronic atlantoaxial instability, like chronic subaxial instability, leads to several secondary manifestations which are all protective. They are not pathological. They are all indicators of atlantoaxial instability. So chronic instability, chronic atlantoaxial instability can be associated with Cary, with syrinx, with bifid, with C2-3 fusion, with Klippel file, with basilar invagination, without basilar invagination, Cary with syrinx, Cary with short head, Cary with short neck, Cary with basilar invagination. All these things which are reported here are all secondary. They are all naturally protective or adaptive, and they are all reversible following atlantoaxial stabilization. So all our muscles are focused on the facets. There are no muscles focused on the disc or vertebral body. Facet is the fulcrum of all movements. Atlantoaxial joint is the most mobile joint, most common form of instability. Subaxial instability may not be seen on dynamic imaging. Weakness of the muscles is the primary issue in facetal instability. In 1999, we said that C1, C2 instability is the cause of basilar invagination, like lumbosacral listhesis. Instability is the issue and stabilization is the treatment. So reduction, 20 years ago, fixed atlantoaxial instability was a common clinical diagnosis, like this is fixed. So when it is fixed, decompression is the treatment. For the first time in the literature, we said that there is nothing like fixed dislocation. Open the joint, manipulate the facet, and you can reduce the dislocation. It is not fixed or irreducible. It is pathological and pathologically mobile. More important is decompression is not the treatment. So this was the first article in the literature. So this kind of fixed dislocation, flexion, extension, no change, no transoral decompression, no removal of arch of atlas, stabilization, and if necessary, if possible, realignment. More than realignment, instability is the issue and stabilization is the treatment. Over the years, we have treated several hundred patients without any form of decompression. We all know that basilar invagination was considered to be a fixed dislocation. And that was the reason transoral decompression was suggested for group A, and group B, foramen magnum decompression was suggested. So this article in 2004 was the first article in the literature where we said that this is unstable. We said group A is unstable. In 2004, we said that group B is stable and group B decompression is okay. But for group A, we introduced the term craniovertebral junction realignment. We said that there is no need for transoral decompression. Stabilization is the treatment, and realignment, if possible, is the treatment. Over the years, as I have mentioned, we have got hundreds of patients, and no question, no arguments, no discussion. Like this kind of patient should not be treated by decompression. Open the joint, distract the facet, reduce the dislocation. That is the treatment. Listhesis was the issue. Cary, syrinx, instability. Listhesis is the issues. Reduction is the treatment. Decompression has no role in the treatment. This is what we said in 1999. As we matured further in this business, we introduced an absolutely different concept of craniovertebral junction, where we introduced the concept of central or axial atlantoaxial instability. And we said that chronic instability is the issue. Chiari, basilar invagination, platybasia, bone fusions, bifid spine, os odontoideum. Not only these, but spinal degeneration, OPLL, Hirayama disease can be a result of central or axial atlantoaxial instability. So this was the first, in 1999, we said listhesis of facet of C1 over C2 is the issue. Reduction of listhesis is the treatment. There is no need for decompression. Another beautiful thing that you will like to see is in basilar invagination, there is no atlantodental interval disturbance, no compression of the brain stem. There is syringomyelia, there is Chiari, but there is listhesis of C1, retrolisthesis. This is clearly an unstable situation. Stabilization is the treatment. Decompression is a negative form of treatment. Third thing is when the facets are in alignment, when there is no atlantodental interval disturbance, presence of Chiari, presence of syrinx, presence of assimilation of atlas, presence of platybasia are all telltale evidences of central or axial instability, even when there is no compression of the cord, even when there is no disturbance of facetal alignment, atlantoaxial stabilization is the treatment. So at basilar invagination is secondary to chronic atlantoaxial instability. Stabilization is the treatment. For both group A and group B basilar invagination, there is no role for decompression. So instability is the cause and stabilization is the treatment of basilar invagination, both group A and group B. Even when there is no facetal malalignment, no atlantodental interval, presence of Chiari, presence of basilar invagination, they are all secondary. They are all indicators of unstable atlantoaxial joint. Look at the facets. Even when the facets are in alignment, there is possibility of instability and stabilization is the treatment. This kind of basilar invagination, the whole world will like to do foramen magnum decompression. Absolutely no role for decompression. There is facetal malalignment, difficult operation, dangerous operation, but this is the operation for this clinical entity because you can give new life, an absolutely new life, a magical life to these patients. So Chiari, syrinx, basilar invagination are all the children of one father, and that father is atlantoaxial instability. Atlantoaxial instability is the cause of Chiari malformation, is a cause of syringomyelia, is a cause of basilar invagination, and the treatment is one. And that treatment is atlantoaxial stabilization. So we have published heavily on this subject. This was my experience with 388 cases. No decompression, even when there are bone abnormalities or no bone abnormalities, even when there is syrinx with Chiari or without Chiari, syrinx with other bone abnormality or without bone abnormality, C1, C2 fixation is the treatment. So no problem in atlantoaxial joint, facetal instability, do C1, C2 fixation and give new life instantly after reversal of anesthesia, and syrinx in 100% of cases when you do imaging after 6 months. You see, this is syringomyelia. This is on the second day of surgery. Do only fixation, no decompression, and you see a magic that you have never seen with decompressive surgery. So even when there is no facetal malalignment, no atlantodental interval, presence of Chiari is an indicator of atlantoaxial instability and atlantoaxial stabilization. I am not saying occipital instability. I am not saying introduce a spacer. I am not saying do distraction. I am doing instability is the issue and stabilization is the treatment. For all types of Chiari, except when there is tumor, when there is spina bifida, those Chiaris are different. But when there is Chiari and syrinx, look at the facet. There is no atlantodental interval disturbance. Do atlantoaxial stabilization, and you see an absolute magic of clinical outcome. Syringomyelia will reduce in 100% of cases if you do imaging after 6 months. There is no compression. No problem here. But C1, C2 fixation is the treatment. So compression is secondary, compression is protective, and compression should not be called malformation or anomalies. They are formations or alterations. They are natural. Chiari is a natural airbag. Cervical fusions are not a pathology. They are not embryological dysgenesis. They are protective. Response to chronic atlantoaxial instability. Bifid is not embryological problem. Problem is your muscles. Problem is the weakness of the muscles. Problem is chronic instability. This article published in Neurosurgery mentioned that this is a protective phenomenon. Os odontoideum is naturally protective. It is this kind of os odontoideum is protective. It is an indicator of atlantoaxial instability. Any kind of decompression will be an absolute negative form of treatment. Only C1, C2 fixation is necessary, not occipital fixation. When there is multi-level bone fusions, there is no atlanto compression due to odontoid process. There is bifid, no compression, but there is clear indicator of atlantoaxial instability, meriting the need of atlantoaxial stabilization. Syrinx is not a primary process. Syrinx is secondary. It is helpful. It is not harmful. Idiopathic syrinx. Syrinx when present with Chiari or without Chiari, with basilar invagination, without basilar invagination, with bone fusion, without bone fusion. This kind of syrinx, you look at the facet, even when the facets are in alignment, do C1, C2 fixation, there is a potential of giving new life to our patients. Musculoskeletal abnormalities like short neck, torticollis, when they are present with other problems, okay, but when they are present discretely, they are indicators of unstable atlantoaxial joint. You do atlantoaxial stabilization, you can give this kind of magical smile to our patient. Kyphoscoliosis in this kind of age group, more often than not, in this age group, if you see this kind of kyphoscoliosis, the problem is not here. Problem is central instability. These are secondary manifestations. Like short neck, there is torticollis. Short spine, there is kyphoscoliosis. Problem is not here. Problem is at the craniovertebral junction. You do atlantoaxial stabilization and you see an absolute magic, a magic that you will never see with multi-segmental fixation and multi-segmental decompression. So central instability can itself be a cause of myelopathy. Like this patient, you see there is small syringomyelia, no compression at the craniovertebral junction. The treatment is C1, C2 fixation. When there is bifid with no problem at any other point, treatment is C1, C2 fixation. So there are many issues in central or axial atlantoaxial instability. Now, my dear friends, I want to turn the page. I want to discuss about degenerative arthritis of craniovertebral junction. Not many people have even talked about it. I want you to see, my dear Tito, can you see the slides? I want you to see very carefully. You see this osteophyte formation, reduction in the joint space, buckling of the posterior longitudinal ligament. These are not primary problems. They are due to vertical instability, due to muscle weakness. The problem is when you see osteophyte, when you see reduction, when you see buckling, the problem is atlantoaxial instability. You don't have to do any kind of decompression. You have to do atlantoaxial stabilization. Ossification in the apical ligament, ossification behind the bones, ossification in front of the bones. They are secondary, they are protective, they are reversible. Fixation of atlantoaxial joint is the treatment. Retroodontoid pseudotumor, the whole world was treating by decompression by the mouth or lateral removal and all those things. For the first time in literature, we said that retroodontoid is like osteophyte, indicates C1, C2 instability, and the treatment is atlantoaxial fixation, and magic is the clinical outcome. So this was the first paper where we talked about retroodontoid mass and C1, C2 instability. So instability is the nodal point of pathogenesis of several problems, And that problem I want to discuss, not only C1, C2, but subaxial instability. So retroodontoid pseudotumor is a secondary issue. Pannus is secondary, cis retroodontoid is secondary, and they are all indicators of C1, C2 instability. Retroodontoid pannus in rheumatoid disease. Many people in the world were doing transoral surgery to remove the pannus. For the first time in the literature, we said that this is due to vertical collapse. You do fixation, the pannus will disappear. There can be immediate postoperative regression of the pannus following C1, C2 fixation. We have talked about C1, C2, but nobody has talked about subaxial facetal instability. Weakness of the muscles of the spine can lead to facetal instability. This facetal instability is the primary issue in spinal degeneration. It is not disc space reduction. It is not disc water reduction. It is not age. It is your weakness of muscles which lead to spinal spondylosis. My dear Tito, I want you to see carefully this slide. Reduction in the intervertebral body space, bulging of the disc, osteophyte formation is not a primary event. They indicate vertical spinal instability. This is due to vertical spinal instability. There is no need to treat this. These are secondary issues, osteophytes, bulges, reduction. These are secondary, these are protective, and these are reversible. So in the year 2010, for the first time, we talked about facetal distraction. Introduce spaces in the facet. The aim is distraction and fixation. There is no decompression. This is preoperative. You see the immediate postoperative, the ligamentum flavum is stretched, the posterior longitudinal ligament is stretched, there is new disc, and there is a facetal distractor spacer. You see carefully this slide, multiple disc bulges, multiple ligamentum flavum bulges. This is immediate postoperative multi-segmental facetal distractor. So the aim was not decompression, the aim was facetal distraction and stability and arthrodesis of the treated segment. So many patients we treated at that time, this is the disc and this is the bulge and this is postoperative and this is the arthrodesis. No decompression. And this paper was published as cover page of Journal of Neurosurgery in 2011. And you see another patient, multi-level disc bulges, and this is immediate postoperative, and this is multi-segmental arthrodesis. So what we introduced with this concept, a new hypothesis in degenerative spinal disease. Same concept we introduced for lumbar stenosis. This kind of stenosis is not a primary, this is not stenosis. This is multi-segmental spinal instability. And we introduced this concept of facetal distraction and spacers. And this paper was published in Journal of Neurosurgery, where we introduced these spacers for the first time in the literature. But as we progressed, we got a new concept. The concept was instability is the issue. There is no need for distraction also. Stabilization is the treatment. Only fixation as the treatment of spinal degeneration and cervical spondylosis in particular. And more recently, I published this article in World Neurosurgery. We said muscle weakness related spinal instability is the cause of spinal degeneration, and spinal stabilization is the treatment, not decompression. Decompression is negative. Any kind of decompression from front or from behind should not be done. Unstable situation, stabilization is the treatment. Do you see multi-segmental bulges? These are not primary. These are secondary. They indicate multi-segmental instability. You do only stabilization. And you see after 18 months of surgery, the entire thing is changed. There is no compression anymore. There is only one treatment which I have done without any decompression, which is multi-segmental stabilization. Similarly, you see this case, multi-segmental compression, bulges here, bulges there. I have done only fixation using Camillus technique, no decompression. And you see after 16 months of surgery, the whole spine is changed. This is after 16 months. But believe me, post-operative, a fantastic, immediate post-operative, magical clinical recovery that we have never realized with decompression. If you ask me, there is one issue which is most important in degenerative spine. Identify which levels are unstable. What are the indicators of spinal instability? That is the question in spinal surgery. You see this case, there are only 2 segments of problem. And I have done 4 segmental stabilization. After some time of surgery, you see both these segments are, I have not done any kind of decompression from ACDF and corpectomy, nothing was done, only stabilization, and magic is the clinical outcome. In severe myelopathy, when the patient comes with severe myelopathy on a wheelchair, on a trolley, atlantoaxial instability is very commonly and frequently associated. You see this patient multi-segmental compression, if you want to call, I don't like to call it compression. I like to say it is divine intervention. Multi-segmental issues due to multi-segmental spinal weakness. There is central or axial atlantoaxial instability. You include C1, C2 in the fixation construct, and you see a magic of the clinical outcome. This is multi-segmental instability. There is no problem in the craniovertebral junction. See, look at the facet, include C1, C2 in the fixation construct. When there is severe myelopathy, C1, C2 instability is very frequently associated. It is frequently associated, always neglected. Nobody in the world has talked about it. Include C1, C2 in the fixation construct. Don't do any decompression from front. Don't do any decompression or laminectomy or laminoplasty or corpectomy or multi-segmental discoidectomy. You will damage the patient. Do Camille's technique of fixation. Include C1, C2. I will talk about C1, C2. C1, C2, we have introduced an alternative form of treatment where we do not include C1 in the process of fixation. We do C2 spinous process muscle resection and do C2-3 fixation. So there is an alternative method which I have talked about, and you must read my papers on the subject. Lumbar canal stenosis, you read this title in Neurosurgical Focus, analyzing the role of stabilization and futility of decompression. You see, very strong statement in Neurosurgical Focus where I've said role of stabilization and no need for decompression. This kind of lumbar canal stenosis, the whole world will like to do decompression. Laminectomy is the gold standard treatment. I am saying laminectomy should not be done. It is not stenosis. It is multi-segmental instability, and you have to do multi-segmental stabilization, and which is a magic form of treatment. Osteophyte, the entire world of spine is dedicated to remove osteophytes or make space for the osteophytes. These kind of osteophytes, you come from front and remove the osteophytes. I am saying osteophytes are secondary. I am saying osteophytes are protective. I am saying osteophytes are natural divine intervention. They are adaptive and protective. They are reversible. They are indicators of multi-segmental instability. You do only stabilization with Camille's technique or whatever technique, and you see the magic and new spinal cord after surgery, after a period of time. No decompression, only arthrodesis is the treatment. This is another case where I've done only fixation using Camille's technique, and you see the complete reversal of these compressive elements and a new spine. Deformities of the spine are treated with kyphectomy and all those kind of decompressive surgery. I am saying deformities are secondary. Deformities are protective. Deformities are reversible. Deformities are indicators of unstable spine. Stabilization is the treatment. This patient needs only atlantoaxial fixation. This patient needs multi-segmental spinal fixation. This patient has central instability. It needs multi-segmental plus atlantoaxial stabilization. These things are discussed in this article of mine, and I wish that you read in World Neurosurgery. Another little bit controversial, to say the least, prolapsed disc is an indicator of unstable spine. Either unstable spine causes prolapsed disc or prolapsed disc causes instability. Only fixation is the treatment. There is no need to remove the disc. This is may look very harsh or very controversial, but this is a absolute magical treatment which I'm showing and which is heavily published in the literature. This kind of single level disc, the anterior ACDF, is a very simple, straightforward technique. Or some people remove only the disc. I am saying you do stabilization, identify unstable segment, you do stabilization, patient will remarkably recover in the evening of operation, and this disc will disappear within 2 months of surgery. So this is the paper which I want you to read in World Neurosurgery as arthrodesis, not decompression, as treatment of single level or multi-level disc herniation. Same thing we talked about lumbar disc. You do only fixation. And this, you just have to, you know what I should say, I cannot say in too many words or too many, but you have to read these articles where I have said that disc is secondary, disc is protective, disc is divine intervention, disc is naturally protective. You do, instability is the issue. Like when you give collar and you stop the movement, pain goes. When you give belt and the person is stable, the pain goes, because we are stabilizing. You stabilize in that position. When you move little bit of neck, there is sharp pain. Little bit of back, there is sharp pain. So instability is the issue. You stabilize and you see the magic. OPLL, the whole world treats OPLL by decompression, and there are potential for huge complications. Those people in the spine surgery, they know it. OPLL is not easy treatment. You do multi-segmental corpectomy, you can certainly harm the patient. You do multi-level laminectomy and laminoplasty, you can certainly harm the patient. My concept, which we introduced first time in the literature, that OPLL is secondary to multi-segmental spinal instability. You stabilize the spine, and this patient will recover like you have never seen with any kind of corpectomy or any kind of decompression. Stabilization, not decompression, is the treatment. Atlantoaxial instability is very frequently associated with OPLL. Inclusion of C1, C2 fixation is an absolutely important issue in multi-segmental high-level OPLL. You include C1, C2. In the fixation construct, not decompression, as I mentioned, there is an alternative C1, C2 fixation construct that we have described, and there is not always necessary to do C1 screw. So this kind of OPLL, do not do any decompression. Do not treat the images. Images are showing compression. Imaging are showing reduction of the spinal canal. Imaging are showing the cord is elastic. Cord is like a rubber band. Cord can do anything. It does not tolerate one thing, is instability. Instability is the issue. So atlantoaxial and subaxial spinal stabilization can revolutionize the treatment of OPLL, can revolutionize the treatment of Hirayama disease. Hirayama disease, I don't know how many people know it, but it is a relatively rare form of problem. And the whole world does all kinds of decompression. If you see carefully, this kind of fat introduction is secondary. It is protective. It is not harmful. You do fixation, the fat will disappear. Excessive CSF in the spinal canal, external syringomyelia, is protective, not harmful. So transoral decompression is historical. Foramen magnum decompression can certainly become historical. I'm saying that anterior spinal surgery can become historical. All forms of decompression are not necessary in spinal pathology. So thank you very much, my dear friend. I hope it is this kind of aggressive lecture, different kind of spinal surgery. But you see, whenever I'm talking on the basis of several publications on the subject. And I wish that you read the Neurosurgical Focus article this month, where I'm talking of various kinds of problems in craniovertebral junction and on various other problems in the spine. So thank you very much, my dear friends. Thank you, Nasser. Thank you, Tito. and all other people on the screen. Thank you.
Thank you, Atul. Let me first express my proudness and appreciation for this very great lecture, great as usual. Atul Goel is not only an excellent neurosurgeon, but he's an excellent lecturer. He knows how to present his work and to simplify everything that we understand it in a very, very simple way. Actually, Atul, I'm proud about this presentation. You are actually an innovator. You changed many concepts in neurosurgery. Thank you very much for this great lecture. I give the mic back to my friend Tito Perella to proceed.
Okay, Professor Aton, later in the discussion, we will have time for answer some question. I know there are some persons who are your hands up, and there are many questions. I will request to them that please, after the next talk, we will be proceed to have big discussion, because today I think is another historical moment for begin to see what is doing in the spine. You will be continuing destroyed with surgery and then reconstructed with metal. To older people, even look the physiopathology that you list, that Dr. Goel in the before talk tell us. If you fix the cause, you fix the problem. Is very sure advice for this. Next speaker is one neurosurgeon who I have too much love and appreciate that this is one neurosurgeon pediatrician, Dr. Solaski Urish, my friend, who all of you know them, and he will be tell us how we can handle this difficult pathology from the first steps of the life in the first years. So his advice for us in clinical, in treatment, and also in diagnostic, it will be important. Willis, coming is your time, and thank you for share all your kindness and all your knowledge with us.
Thank you, Professor Perella. Can you guys hear me, or am I still on mute?
It's very good.
Perfect.
Perfect. Okay, so thank you, Professor Perella, for your very kind introduction. I'm also very grateful for the inspiring talk I just heard from Professor Goel. Some of the points that he alluded to, I will be also alluding on my talk. It gives me really great pleasure, and I'm privileged to be part of such an honored group of speakers today on such a complex topic. My job or my task today will be to talk about the pediatric aspects. Clearly, the complexity in adults is equally daunting. None of the work that we do is in isolation, and I've been privileged to have a group of very experienced anesthetists, neurophysiologists, and neurosurgery colleagues who have kept me safe all these years and allowed me to progress in the work. So no conflict of interest, of course. So I just wanted to start with the background between the differences between pediatric and adult craniovertebral junction. And you know that in adults, mostly the surgery that you're involved in will involve either trauma or inflammatory conditions, and less congenital anomalies, which are pretty much dealt with in the sort of teenage and pediatric ages. And this is what we find more. Then the other stuff that we often find in pediatrics, the association of these anomalies with Chiari and syringomyelia, and Professor Goel has clearly opened our minds, and you know, the horizon has expanded immensely with the theories that has been proposing. But this condition is also associated with respiratory and neurological problems. So we need a multidisciplinary approach prior to any surgical intervention, essentially to avoid morbidity and mortality. What I'm going to present today is actually the experience of our very first 50 cases, where we're still kind of on the learning curve. We've now done just over 100 cases of pure craniocervical junction surgery in children. So I'll start with the embryology. Of course, this slide is very crowded, but you'll be pleased to hear that the only important part of the slide is this, the red square. So of the 4 occipital somites, only the 4th occipital somite, which will then progress to become the pro-atlas, and the first cervical somite, which become the inferior part of the posterior arch of atlas and odontoid process in part, are the relevant for us. And this will lead to all of the 7 items that I've described here below: anterior tubercle of clivus, anterior foramen magnum, anterior and superior part of the posterior arch of atlas, the occipital condyles, lateral masses, the apical dens, and the cruciate and alar ligaments. So pretty much most of the stuff that we're going to see is going to come from the 4th occipital somite and the 1st cervical somite. So what are these skull-based lesions? Starting from the very top, so the occiput and atlas, the commonest thing that I often see is a simulation of atlas, where the occipital condyle fuses the lateral muscle C1, and you get loss of motion, which is the flexion extension motion is lost. Now, you still have to say yes to people. And if you can't say yes with C0, C1, you're going to be forced to say yes with C1, C2. However, at C1, C2, the motion that allows us to say no. So to be able to say yes in a joint that is made to say yes, you'll develop laxity of the cruciate ligament. And that will lead to C1, C2 instability, and that will lead to all the stuff that Professor Goel has just been talking about, the facetal instability and the lateral mass instability and malalignment. Then you have the situation with the pro-atlas homeotic transformation. Professor Pang has discussed this extensively, and what happens is the 4th occipital somite suffers a clocking problem. So instead of the normal transformation of the pro-atlas, you suddenly develop a very short stubby clivus. And there's even a case report from Professor Goel's team where the clivus is completely absent. Then all the bony material, instead of disappearing, actually becomes part of the dens, and you get an elongated dolichoid dens. And this elongated dolichoid dens often bends backwards and causes brainstem compression. And so those are the significant problems that we face. And then the third issue that we often have is the odontoid dysplasia hypoplasia complex, where the C1, C2 lateral masses will move separately because there is no more impediment by the cruciate ligament. So the atlantoaxial instability will then lead to chronic spinal cord compression and myelopathy. A typical example of that is orthodontoideum, where the cruciate ligament is actually between the body of the dens and the orthodontoideum, and is no longer holding C1 and C2 together, causing cord compression. You can also have unilateral C1 and C2 lateral mass hypoplasia, which will lead to luxations, deformity, and compression. So that's the third issue. And then the fourth issue, which I normally see, are the fusion anomalies. C0, C1, we talked already about that. But most of the assimilation of atlas fusions are also associated with C2, C3 fusion, the laminar fusion of C2 and C3. So what happens? The only joint that can actually move is C1, C2 joint, and that will then lead to instability. And then the subaxial fusions, the Klippel-Files, Noonan syndrome, they're not as popular or as commonly known, but they can cause significant problems as well. And Professor Goel alluded to subaxial facetal instability, but fusion anomalies can also lead to, the joint above and joint below pseudo instability. And then I also wanted to bring this topic of basilar invagination. Now, I do apologize. I missed previous lectures because I was actually at a different talk or event. But what I wanted to point out is this important aspects of measurement, craniometric measurements. If you look at the coronal image, the bimastoid line usually crosses the condylar joint, so the C0, C1 joint. And in basilar invagination, of course, it'll be way below, or sometimes below the C1, C2 joint. And on the sagittal view, the Chamberlain's line, which is a line that you draw from the hard palate to the opistheon, is a line that generally crosses the anterior arch of C1 and the tip of the odontoid by 1 or 2 millimeters. So any digression from this, particularly if the tip of the odontoid crosses the Macrae's line, which is a line between the Bayesian and opistheon, then we are looking at typical basilar invagination. Now, pure basilar invagination is unusual. It's usually associated with platybasia or with another condition called basilar impression, and I will explain the difference. In basilar invagination, there is an infolding of one part within another part, and in this case, we're talking about the odontoid moving inside the foramen magnum. And the commonest causes in my practice is C1 lateral mass hyperplasia or assimilation of atlas. In basilar, so this is, sorry, my apologies. So this is, as you can see here, the bimastoid line is showing nearly at the level of C2, C3 joint. It should be at the level of C0, C1 joint. So this is typical basilar invagination. You can see the tip of the odontoid is well inside the skull. And on the sagittal image, you can see that as well. Now, basilar impression is a different thing. Basilar impression is indentation or depression produced on the surface of an organ. It means something is pushing it by outside. And this is caused by softening of the bones, like in osteogenesis imperfecta, rickets, fragility, bone fragility disorders, AD chain of disease, spondyloepiphyseal dysplasia. In these conditions, the skull is too soft. And the upward movement, so the downward, the weight of the skull is pushing the skull downwards into the spine, like a lollipop on a hot day, sliding down into the stick. What happens is you get infolding of the lateral wall, the posterior wall, and anterior wall of the skull. And that infolding is associated with upward mobility of the tip of the odontoid. And although both of them appear to be basilar invagination, the causes are completely different. And you can see here, osteogenesis imperfecta on one side, assimilation of the atlas on the other. Now, in pediatrics, the other large section of my practice is mucopolysaccharidosis. These are enzyme blockages, so enzyme deficiencies, and the typical ones are mucopolysaccharidosis, MPS type 1 to 9. The ones that I commonly operate on is type 1, type 2, and type 4, and type 6. These are the ones that commonly come to my practice. And this is an example of a child with Morchio, MPS type 4. You can see the development of the bone, the ossification is enzymatically blocked. So the bone is more like cartilage. And you can barely see the bone on the X-rays and CT imaging. But on the MRI scan, you can see that there is significant instability. So you get atlantoaxial instability in nearly 100% of the MPS 4 children. And they will all require some degree of decompression and fixation. And again, as Professor Goel was alluding, if you get the correct alignment, and I tend to use this procedure, what people call Goel-Harms technique, and often you don't have to remove the posterior arch of C1, which you can then use as part of your fixation. But it depends on individual cases. So this is an example of another condition that we have identified, Walcott-Rallison syndrome, and I'm pleased to see that Professor Nick Thomas is on the speaker panel. So both Nick and myself were co-authors on the first paper that reported the association of Walcott-Rallison syndrome and ostodontoidium. So this was previously unreported. And what we discovered is that these children who have very severe congenital neonatal diabetes from consanguineous births and associated with liver dysfunction also have epiphyseal dysplasia. But what we discovered is that there's a specific mutation. And in this particular series of patients, all of them had ostodontoidium, which was associated with neurological deficits. And the series of 4 patients that we shared all underwent surgical fixation. And this abnormality had not previously been described, and of course now is well known, and it's something that is very eminently treatable. So if I were to summarize, craniocervical disease progression in pediatrics, and if you were to think about what is it causing, well, it can cause compression, instability, deformity, But in my experience, all of them are combined. So there's no such a thing as just compression or such a thing as just instability or deformity. And you have to strategize and formulate your treatment to deal with all of these problems. This is a typical example of a pediatric MPS 4 child. You can see that at the time of diagnosis, usually about the age of 2 years, they don't have significant compression. There's CSF, both ventral and dorsal, at the craniocervical junction and the range of the whole of the cervical spine. But as time passes, within a few years, you lose CSF, then you start getting tickle compression, you get instability and myelopathy. So the important thing that we've discovered now is that by the time they get signal change in the spinal cord, it's too late to operate on them. You can't wait until then. And the radiological reports say, oh, no change. But what we are looking for is subtle change. And we want to be able to operate on a child somewhere between the second and the third picture, where the child is clinically well, and the ability for us to actually cause stabilize disease without neurological deficit would be best. So that's one message here. Of course, the same applies to the rest of the spine. Now, this is a series of images on the same patient, and you can see how initially the patient had a nice S-shaped curve, and then it starts losing the nice curvature and becomes more straight, and then it starts angulating. And the two typical sites of angulation is the cervical-thoracic junction and thoracolumbar junction. And you get this L-shaped curves. And then, of course, as they become more severe, they lead to compression. And the commonest sites of compression are the thoracolumbar junction, cervicothoracic, and atlantoaxial compression. And the typical appearance of a child at this age, about between 5 and 8 years, would be something like this, requiring multiple surgical interventions at multiple levels. And that is just talking about spine and not talking about orthopedics and all other interventions that these children require. So this is a kind of physical appearance of children who have no neck, very short neck. They have macroglossia. So when you operate on them, anesthetic complications are significant. They have pectus carinatum. Putting halos and braces on them are extremely difficult. So these children, of course, a very short height as well. They are a very challenging group of patients to operate on. And we perform neurophysiological monitoring on virtually every one of them and develop very specific criteria, which we call alert criteria, that have kept us safe. And that includes a 50% reduction in cortical amplitude with the SSEPs, 80% reduction in response on the MEPs, and brainstem auditory responses as well. So when, before all the responses are lost, we get an alarm. And that alarm tells us that something is happening, but has not completely happened. And that allows us to stop in time. And we've just recently published our experience where we were able to avoid a predicted 80% of neurological deficits, which we avoided by taking preemptive action with this alarm criteria. Now, in our first series of 50 children, we looked at what was our commonest presentation. As I mentioned, the metabolic and skeletal dysplasias accounted for nearly half of our patients, and then all the congenital anomalies. Trauma actually was a very small group, just about 12%, and then there was lots of syndromes like Downs, Ehlers, Danlos, and so on. This is something that pretty much all of the practices will have. And when you look at this, and you remember I talked about instability, deformity, compression, and it is so interesting that when you put them together, all of them have most of the conditions. So there's nothing like treating them in a very different way. Most of them require the very similar management. And so what sort of complications we get with this sort of challenging cases? Well, fortunately, the biggest complication we've had so far is wound breakdown. These children are also nutritionally deficient, vitamin D hypovitaminosis. We've had 3.7% of the children, that is two children out of 50, have suffered transient weakness, which recovered with hypertensive therapy and went home well on discharge. But we have had one case of permanent deficit, which is a paraplegia from a remote spinal cord infarct. The rest complications are minor and treatable as well. So what I wanted to do now with the remaining time is to show some cases, because the cases would allow us to illustrate the kind of work that we do. So this is the child that we referred before with MPS 4. And as you can see here, they have significant subluxation. And at this point, the intention here is to correct that subluxation. And as I mentioned, I often don't take the posterior arch of C1. And you can see here the posterior arch of C1 is intact. But what I do is I use the C1 lateral mass and C2 laminar screw, or I send the screw as high into the isthmus as I can. And then by tightening the rods, I'm able to align them. And this is pretty much the pre and post-operative correction that I achieve. And this usually works for me. So this technique I've been using for more than 20 years now successfully. And in most cases, I do not have to remove even the posterior arch of C1. In some cases, I've used recombinant human bone morphogenetic protein type 2 to optimize the fusion. And you can see this is between C1 and C2. This is collagen, which has been instilled with BMP2, so a very focal application. And the fusion occurs within 4 weeks. It's very rapid fusion. Now, one of the things we discovered is that dense hypoplasia is supposed to be a part of the MPS 4 syndrome. In fact, in our series, every patient that we have fixed as other dents develop subsequently, which leads me to think that the dense hypoplasia in MPS 4 is a traumatic orthodontoideum or dense hypoplasia because the fixation has allowed the dents to regrow. So if it was part of the genetic profile, the dents would have not grown. And you can see the approximation of the C1, C2 joints following fixation. These are the children tolerate the halos reasonably well. The parents suffer more than the children, I often say, and they seem to be very happy. The second case I want to talk to you about is a child with craniovertebral junction, platybasia, basilar invagination, dolichoid dens, atlas assimilation, and ventral brainstem compression in Chiari. The typical symptomatic presentation. This child also had craniosynostosis and had undergone a previous frontal-orbital advancement and Calvary augmentation for Cruzon syndrome. The child presented to me myelopathic, and you can see the anterior arch of C1 is here, and the dens is quite abnormally placed and is moved into the skull, causing compression. The child also has got a Chiari. Fortunately, didn't have a syrinx. So in this situation, looking at the CT scan, this is what Professor Goel has been talking about, and I very much started looking at these things after I met him in 2015 and realized a lot of the mechanics of basilar invagination. So this is, for example, one of them. Can you see, this is the lateral mass of C1, and that's the C2, the lateral mass of C2. And that's supposed to be an horizontal joint. But in basilar invagination, with assimilation of atlas, the joint becomes vertical. And this is the problem. This is actually the posterior arch of C1. So we have to deal with this problem. And as you can see here, how are you going to put a C1 screw when the C2, the whole lateral mass of C2 is in front of C1 lateral mass? So the first thing that we often have to do is a distraction so that C2 comes down. And only after the distraction, we are able to put in the C1 lateral mass screws. So now you can see here with the occipitocervical fixation that we performed in this patient, we put in C1 screws. You can see the simulation of atlas with fusion occiput and C1, and then C2 screws. And you can see that we were able to bring the tip of the dents down all the way down here to about something like 15 millimeters or so. And this then allowed the normalization of this child's problems. I didn't show the post-op MRI scans, but they significantly improved. Just for brevity of time, I want to take you to another case, which is cervical kyphosis. So cervical kyphosis is common in children because of neurofibromatosis. In my practice, NF1 is associated with a lot of these conditions. And this is a typical severe case of cervical kyphosis where you can see elongated C2, C3, C4, C5 are actually buried between C3 and C6. And the bones are completely eroded because of the the osteopenia and the sort of the vascular steel phenomenon that happens in neurofibromatosis. And you can see the severe spinal cord compression here. So when I discussed, this is not something that I normally operate on. So I took a lot of advice, and everybody told me you have to do a corpectomy of C3, 4, 5, possibly C6, and then a fusion of C2 to C6 or C7. And I thought for pediatrics, that would be too much of a call, and that she would permanently lose neck height. And then in collaboration with some of my spinal orthopedic colleagues, we decided to look at whether we could distract this child and do posterior fixation first, and then gradually come back and do an anterior fixation. So that's what we did. We started treating with the low vitamin D divers, put on a halo, distracted every week under interactive neuromonitoring. And as we started getting some gains, we then decided on a combined anterior and posterior approach, but decided to do the posterior approach separately first as we got significant improvement. So I'm not going to spend too much time with the technique because you guys have done a lot of this. You are masters in this surgery, but this is the example of in a table distraction and the complete muscle paralysis, and then a posterior fixation to start with. So what we did is we were able to distract all of them into a position where we could carry out an anterior fixation without losing a single vertebra. And we carried out a C2 to T1 posterior facet, lateral mass facet, and laminar fixation and distraction to the point that we were able to get the alignment we needed and carry out the fixation. And then a few weeks later, we went back and did an anterior fixation, which allowed this girl pretty much normal activity without neurological deficit and without loss of any segment. The other case that I wanted to bring to your attention is platybasia with Chiari malformation. So this is a constant discussion about whether we should do a foramen magnum decompression on these patients or whether we should carry out a fixation. And as you heard from Professor Goel, that some of these patients can be, their Chiaris will improve with the simple fixation. And when I see situations like this, I am tempted, particularly when I feel that there's basilar invagination, to do a distraction and fixation and reassess. And this child particularly had swallowing difficulties and had the evidence of basilar progression, a basilar invagination progression on serial imaging. So for that reason, I then decided to carry out C1, C2 distraction and fixation. And following that, what I wanted to show you is this. You can see the Chiari, the tip of the Chiari malformation was at the level of nearly C4. So this is C2, C3, C4. And following the fixation, without any foramen magnum decompression, as you can see, the foramen magnum is completely intact, the Chiari is regressed to the level of about C2. And this is the sort of thing that is difficult to believe, but once you do these cases, then you start discovering that it is possible that by improving the CSF flow, you're also then providing the mechanism for retraction of the tonsillar hernia. This is examples. Now, this child actually, this is the first child that we suffered a fracture of the rod. Now, I don't know whether it's because of the forces related to the distraction and because we did not get a proper ossification of the C1, C2 joint, but this is the very first fracture of the rod that we've suffered, and we are looking into that. Now, I'm getting pretty much towards the end, but I have one or two more cases to show you. Now, this is one where we suddenly had a patient that presented with ossodontoidium, but also had a retroodontoid mass. And Professor Goel has alluded to this on his talk. And this retroodontoid mass was causing severe cord compression, the stability of the ossodontoidium. So in this situation, we identified that this child actually had pseudochondroplasia. And this, of course, is a rare autosomal skeletal dysplasia, which is caused by a mutation in the cartilage oligomeric matrix protein, which is the COMP gene. The diagnosis, of course, is clinical radiological, but the important thing here is that these children are dwarfs like children with achondroplasia, but they have severe premature osteoarthritis, which children with achondroplasia don't have. So this is the difference between pseudoachondroplasia and achondroplasia. That children pseudoachondroplasia have of course the gene is different, oligomeric matrix protein, but they have osteoarthritis. And the children with achondroplasia is a gain of function mutation of GFR3 receptor, and it results in accelerated fusion with spinal canal stenosis, dwarfism, and often ventriculomegaly. So what is so why do we need to get the correct diagnosis between pseudoachondroplasia and achondroplasia? The main reason is because in pseudoachondroplasia, you develop atlantoaxial instability and cervicomedullary compromise because of the odontoid dysplasia and the retroodontoid mass. In achondroplasia, on the contrary, you have no instability. You have spinal canal stenosis and foramen magnum stenosis with ligamentous hypertrophy, causing cervicomedullary stenotic compression. So this is the reason. Here's our case with the retroodontoid mass, spinal cord compression, also odontoidium. You can see the ventral mass there. The CT scans demonstrate this. We carried out the fixation, and you can see the decompression following the fixation. We did no decompression posteriorly, just correction with the Harms-Goel technique. And sequentially from 2016 to 21, the myelopathic signal change also improved. And the interesting thing was that the retroodontoid mass disappeared spontaneously. We did not have to do anything to it. And you just heard from Professor Goel that the retroodontoid masses are very much an occurrence due to instability. And if you fix the instability, the retroodontoid mass or masses elsewhere will disappear. For those who are interested, this is a series of 53 patients which we published a couple of years ago, describing that they spontaneously regress or disappear after surgical fixation without surgical resection. This is the reference, we were quite interested to see that this was our first case, but Professor Goel has got 53 cases. Okay. Take-home message: the differentiation from achondroplasia is crucially important for surgical decision-making. Where the diagnosis is unclear, you got to run the genetic testing. It's extremely rare to get a child with achondroplasia and orthodontoidium or cervical instability. They get cervical stenosis, not instability. So if you find one, do the genetics. Here's a case that recently came to me. I don't know whether it's achondroplasia or not, but it's been presented as achondroplasia. I suspect it might turn out to be pseudoachondroplasia. This is an unknown skeletal dysplasia, different case. And you can see in this child, this is the arch of C1 or pistion. This child has already presented to me with severe dysphonia, orthodontoidium, basilar impression, severe cord compression, this is a refugee from Syria. We lost in the troubles of war, and then presented to me in this situation. As you can see, the red line shows us where the foramen magnum is supposed to be. This child is orthodontoidium with the os inside the skull. And I really worried that even an attempted distraction, the os may not actually come down. But fortunately, I carried out a C0 to C3 fixation. And fortunately, the orthodontoidium, which was orthotopic, came down with C2, and I was able to successfully decompress this child and avoid the potential risk of tetraplegia. I'm going to jump this because there's brevity of time. And I just wanted to finish now by saying that the big challenges in pediatrics is congenital and metabolic conditions. There's no doubt about it. Poor wound healing in this patient is very common, and in 7% of our patients, we ended up having to do some wound repair on these children. I think that for all these children, you need a complex spine unit, mandatory MDTs, expectations, dealing with expectations, psychological well-being of the children, and of course, support for the parents. We need very extensive cardiac assessments. Most of them are cardiac disease, respiratory, ENT, metabolic, and skeletal. Careful pre-workup and post-op monitoring. And of course, very skilled anesthetists. I'm very privileged to have a fantastic group of anesthetists who can deal with common emergencies. But also ENT and respiratory support available. Occasionally, you may have to do an emergency tracheostomy with these children. Nasopharyngeal airway, all of that. And then, of course, very good surgical pre-planning, anatomical suitability for fixation, screw dimensions, fixation techniques, all of the stuff that you do it because you already know how to do it. But I think for the young people in this audience, it's extremely important that you don't meander into this sort of procedures without adequate experience, and take your time learning how to do this before you jump into it. Monitoring, absolutely. I think I would be very anxious about doing these cases without monitoring now that I've been doing it for the last 15 odd years. So I think one of the things that I didn't mention was the volume changes in the airway, but I think we can leave that for another time. And I'm going to conclude and thank the audience for the time you've taken listening to me. Thank you.
Thank you. Thank you very much, Girish, for this great talk. Actually, it's very important talk about pediatric neurosurgery. Now I give the mic back to Tito Perilla and Atul Goel to proceed into the questions over the panel, and then we open panel discussion.
Before panel discussion, I'll just like to compliment Girish. You have now got a very big collection of wonderful cases. I was very happy. You know, 2 years ago, you did not show these kind of very beautiful cases. Now that the collection is increasing, I think you are doing fantastic work, Girish. No question about it.
Thank you, Professor Goel. I appreciate any comments that you make. This is, of course, very difficult work, and as I mentioned, it's not me alone; it's a whole team. But a lot of the stuff that I've been able to do is because I've been able to listen to, the giants like yourself, Professor Perilla, Professor El-Ghandour. I can see Virendra and Professor Thomas as well here. So it's all learning from everybody. Thank you.
Okay, there are some questions. Excuse me. There are some questions that I will like to send to the panelists for Dr. Oscar. There are two questions. One is, what happens if sometimes we have one injury of vertebral artery? How you handle that problem? You repair, you make the graft? Oscar, this is one question from Dr. Mehmet, and I would like to know what is your opinion.
Sinha, would you unmute yourself, please?
Yeah.
Sinha, this question for you.
This is for Dr. Oscar.
Oscar?
Yes, it's for Oscar, who speak about the vertebral artery.
Yeah.
Can you
How
answer, Sinha, because you couldn't see Oscar?
Okay.
If there's a vertebral artery injury, we have to repair it. There's no doubt. Or there's a
vertebral artery. Dr. Sinha, let me also. Sorry to interrupt.
Yeah.
The vertebral artery injury during C1, C2 fixation can occur in various places.
Yes.
And that is the most feared issue when one is going to operate on C1, C2. That is the problem. That is, he's always worried about whether when you put the C2 screw, you can damage the vertebral artery. During dissection, you can damage the vertebral artery, because this is the issue. And you have to protect yourself. You have to protect the vertebral artery during but it happens then when you're putting the C2 screw, suddenly a big blood comes, and that is, if you want to repair, you just cannot repair. So
It's
what
difficult, yes.
at that point of time, you just put the C2 screw and tighten it, and that is the end of the story. And most likely, I have damaged several vertebral arteries during the course of several years. And there can be a problem, there can be a very big problem, but to sort out the problem at that time, you cannot drill and find the vertebral artery hole, and you cannot do it. So you just tighten the screw. The problem occurs when you are tight, when the vertebral artery laceration occurs in the lateral mass beyond, when it scores in the beyond the lateral to the lateral masses. There on some occasions, because there is so much venous bleeding also going on at that time, you can have a very serious problem. So if you can manage to take 1 or 2 stitches, that is the best. But if you are not able to manage because of the venous bleeding, arterial bleeding, it may not be a bad idea to quickly sacrifice the vertebral artery rather than, going and taking and all those things. Because vertebral artery compromise can be quite easily handled by the other vertebral artery and other arteries in the brain. And it will be very rare that there can be a complication. So if you can manage, then you take 1 or 2 stitches. But if you cannot manage and you are struggling too much, it may be not a bad option to just ligate the vertebral artery quickly.
I mean to, if it is
excuse me.
visible, then we can put a suture. Otherwise, it is difficult task. So many curves underside the bony structure, difficult. But what about the after surgery? We can put the stent.
Tito,
Yes.
you are mute. Tito?
Yes, excuse me, we have to have one order. The issue is Dr. Goel makes one comment. If Dr. Oscar is there, something they want to speak? No. And also, I made one comment about the Dr. Atom Goel said. The best way is putting again one screw with very big could be a piece of wet, wherever, to try to stop and close the hole. Otherwise, if you begin in that time to try to repair, for sure, the patient will be die. But this tells one situation to us. In my opinion, always, I made before angiography, because you have to see if how it's working in functional step, the angiogram for see if you have in the right side of the dominant artery or is not dominant, because depends of it. If you close this later, I did many times for Hell and other surgeons, I made bypass in the case that you are in the dominant artery, bypass from the occipital or high flu to the pica, and also near of the basilar artery. Of that patient will be die if the dominant artery was damaged. This is my recommendation. It's very helpful. See, before, now we have more like we see in your talk and all talks, that you have more information that be for performance one safe surgery. Okay, now if you have another comment, please.
I am also the same opinion. Preoperative angiography is very important, and when you to the dominant artery, then a bypass may be needed.
Okay, there are another question that is for I think in some cases of athletic pains, was no need for fixation? This is one question who made for the Vadim from Russia, that what he's seen about the fixation in these athletics patients. Vadim, you there, please?
What's the question, Tito? Can you say again?
If the Vadim sink in the case of the athletic patients, what he need fixation or not?
Vadim, are you here? I can see he is joining it. Can you hear the question directed to you, please?
The question if the athletic patients need or no need fixation.
Anyone like to answer this question? Girish. Girish, would you unmute yourself, please?
I've unmuted myself. Sorry. Well,
Thank you. Thank you.
apologies. I couldn't understand. What was the question? If you repeat it, Professor El-Ghandour, I should be able to answer.
Excuse me, if in any case, in a special, in any athletic patient, you need or no, you recommend or no recommend fixation?
In athletic patients.
Yes. Yes.
Yes.
Okay. So for which condition?
No, don't say anything. Because there are one talk, excuse me, there are one talk in the that seen from no, this is not for you, Guris, it's from the person, the speaker from Russia, that he speak about the surgeries in the athletic person.
Okay. Okay. Yeah. I mean, the important is if in the absence of Professor Vadim, for example, if it is a pediatric patient who has got instability and the patient is an Olympic athlete, I don't think there's any option but to carry out a fixation. The risk of injury in such children is significant. Now I see Virendra is putting his hands up.
Yeah.
I've had several such children that required some form of stabilization, but it is a judgment call, particularly if there's no neurological deficits. And often we have to take the parents in consideration, the physios and the managers and other people who are part of the national team to give us advice on this as well. So I leave that pretty much open. It's important to understand the context of the question, but I think Virendra wants to say something.
Yeah, in his talk, he mentioned that if there's an instability, he fixed most of the cases. He's shown the cases also. So if fixation is necessary, should be done. He also mentioned his lecture.
Can I make one quick comment?
Yeah.
The doctors who look after cricketers who are fast bowlers see a very, very high rate of spondylolysis. It's a common injury. And when you talk to them, virtually none of them have ever had a spinal fixation. They get managed non-operatively, they recover, and they get back to first-class international bowling without surgery. I think there are many conditions which one may consider to be unstable, pain generators that can be managed non-operatively. And we have to look at those non-operative management strategies very, very carefully. Surgery is not required. We've gone beyond this concept of a broken bone needs to be fixed surgically. It really is not true.
I think, Nick, that is absolutely true. And we hardly ever fuse these patients, isn't it? I was talking about the cervical spine.
Oh no, I was just no, I was alluding to Professor Vadim's lecture, not your comments. Yeah.
Oh, okay. Excuse me. Now I have one question for Professor Atun about his new concept. I think for sure the instability because the deficit of the ligaments start the problem, because you increase in that situation the stress in the disc, in the facet, and everything. You speak about the fixation, but is a mean fixation, is a stabilization, is a mean fixation or arthrodesis? Because if you have one in older persons, you made some kind of fixation with the osteoporosis and many other causes. If you don't get really arthrodesis, that kind of fixation will be in the while have more problems. How is your recommendation for maybe a stabilization that I seen is the concept? Because if you get a stabilization, you stop the movement, and this stop the increase of osteophytes and everything, and also maybe reduce that you are showing us in your cases. And also I have some experience in that when you are working for a long time. So tell me about this concept, please, Professor Atun.
The concept is that age is not the issue. Old age means nothing. If you are doing exercise, if you are running, if you are jogging, if you are gymming, and if you become old, you will never, and if you are thin, you will never get degenerative spine. On the other hand, if you think that you are retired, you think that you want to sit, you think you don't want to walk, you think you are old man, you will like to walk slowly. If you have that kind of mindset, you will certainly get spinal degeneration. So the answer to that question is, age is not the issue. You are the issue. You must keep your body tight and fit and strong. Like you see Girish, see his body thin and lean. If you can keep this body thin and lean, you will never get degenerative spine. On the other hand, if some people, I introduced this concept of vertical spinal instability, vertical, like telescoping of the sky. So if you are horizontally big, you see, if you become horizontally big, then you can become vertically short and you will get degenerated. So the answer is, don't become horizontally big. You will never become vertically small. So your body is very important. You take care of your body. God has given us a beautiful body to use it to the maximum. Run, jog, work hard. If you use your brain, you will never become, old in your brain also. If you think that now is the time to just sit down and don't think, don't work, I have got examples of several brilliant people who have worked till 90 years with using their brain. They never become degenerate in their brain. So God has given a beautiful body. Don't misuse it, disuse it, abuse it, or injure it. Sometimes injury is a big problem. Like disc herniation, you lift heavy weight unnecessarily, without care, and you make your disc herniate and spinal instability. And also, when there is a instability, when there is pain, pain is the first sign of unstable spine. Local pain, radiating pain, even if your MRI is normal, even when there is MRI showing no problem, no herniation, no osteophyte, but if there is a severe radiating pain, it is a sign of unstable spine. And you should handle it and you have to treat it. Like if you have an MRI which is completely normal and there is claudication pain, it means there are multi-segmental spinal instability without radiation, without radiological demonstration. So there are multiple things. One is radiological demonstration, second is clinical evidences, and third is intraoperative. So when I talk about what are the factors what segments are unstable is the most critical issue in degenerative spinal surgery. You have to identify on the basis of radiology, on the basis of clinical, on the basis of intraoperative. If there is disc at one level, and you open the adjoining level, you might find unstable. So, unstable by just manipulation of the bone. In Chiari malformation, for instance, Chiari malformation. Next time you do Chiari malformation, you do one thing for me. You just hold the C2 spinous process and move it like this. It will be tremendously unstable. You do the next time, you do it. So it is manual manipulation of the bone that you can see and you can identify marked instability in Chiari malformation, and you have to do fixation. So there are various issues in spinal instability. This is a very, very huge subject, but this is the subject. When your muscles are not working properly, one thing will happen, that is spinal instability. And all other things which are seen on radiographs, which are demonstrated on compression and ligamentum flavum buckling and osteophyte formation and disc space reduction, spinal canal reduction, these are all secondary issues. The issue is one, your muscle weakness. Ditto.
Thank you. You know me, I have from tomorrow, I will be run 2 hours a day, 1 in the morning, 1 at night. Okay. So, I have to say that for me was a great honor, Nasser, and all speaker. From the beginning to the last, all friends, and in special, you are very good master. Why? Because you are very good teacher. All talks from today teach something. You give only your experience. You come here to teach, to share with all audience, all persons that have been in this webinar have to go to his home happy, because we have new concept from all of us, from all of master, give with care, with experience for putting in our brains how to treat and give better care to all difficult pathology who all of us will be in any time, maybe one trauma surgeon, maybe one skull-based surgeon, maybe one vascular surgeon. All of us will be related with the neck and the skull base, the cervical junction, because this is the most useful junction of the whole body. So thank you for all this, for all knowledge, and for all of care and your patience and your time.
Thank you, Tito. Before closing the webinar and giving the mic back to Atul Guel to say his closing remarks, anybody would like to say any other comments from the panel? And so at the end of this webinar, I would like to thank all our distinguished speakers, participants, and my dear friend Atul Guel to be organizer with me in this webinar, and my big friend Tito Perella to be the moderator. Thanks to all of you. May I not forget to thank organizing team and thank Hassan Ala and Ahmed Magdi for helping me much during this series of webinars. Now I give the speech back to Professor Atul Guel to say his closing remarks and to close the webinar.
Thank you very much, Nasir. First of all, I must thank Nasir for his wonderful, you see, he's a leader. See how many organizations, how many societies he has collected and made such a big forum. Today, I see on the screen 300 people participating on the screen, other than YouTube and other than Facebook and all those things. I think this show must have been watched by at least 1,000 people. Nasir, what do you have to say about that?
Yes,
Excellent, manager.
that's right. That's
So I think this kind of message that you have been able to percolate in the masses of neurosurgery, I think big credit to you. And Tito, my friend from Colombia, Bogota, he was such a wonderful host in Bogota when I visited him. My dear friends on the screen, Nick, Girish, and dear Vadim from Russia, and Virendra Sinha, of course, we have spent a lot of time together in this journey of neurosurgery. Thank you very much, all of you, and best wishes. Take care. And I think, Nasir, should we say bye-bye now?
Thank you. Thank you very much to all of you.
Bye-bye.
Thank you. Thank you.
Thank
very
you.
much. Goodbye. Thank
Great
you.
meeting.
Thank you.
Thank you. Goodbye.
Great
Thank
meeting.
you.
Bye-bye.
Thank you.
Thank you and goodbye.
Goodbye.